Thank you for starting the recording. Good morning.
Good morning.
My name is Dawn Mautner. She, her, and Aya are my pronouns, and I am serving as the chair of the Public Employees Benefits Board. Thank you for joining us this morning. We are going to get started with this meeting of PEBB, and we have a pretty packed agenda. So thank you for joining us. Are you able to hear those of you online?
Yes, we can hear you.
Thank you. I'd like to go ahead and ensure that we have a quorum present. I'd like to call this meeting to order and take roll. Chicky Flowers, are you with us? Not hearing from Chicky yet. Emily Wang, are you here with us this morning?
Yes, Emily Wang is here.
Thank you, Emily Wang. I'll try to get that right next time. Kimberly?
I'm here, thank you.
Good morning. Greg?
I'm here, thank you.
Siobhan?
Here.
Sean? Andrea?
I believe she's excused.
Okay, Andy is out this morning, I believe, and I'm here. So we have quorum. Do we have Rep Nose?
He just emailed that he's on vacation.
Okay,
So
thanks.
just this morning.
All right. Thank you very much. Welcome to this meeting. There's quite a lot going on with the best and final offers coming in. So do we have a motion to approve the minutes for the last meeting?
This is Kimberly. I make a motion that we approve the minutes as presented from the last meeting.
Thank you, Kimberly. Do I have a second?
I can second Greg Clauser.
Thank you, Greg. All those in favor say aye.
Aye.
Any opposed? Hearing none, the minutes are approved. Kelly, would you like to?
Yeah. Everybody, thanks for joining us today. We have obviously a lot to go through. Just wanted to set a little bit of the context for this meeting, and we will talk about this as well. We have best and final offers from the carriers. So that was the final round of negotiations, and the board now has some decisions to make around plan design and funding to get down to our 3.4%. We do have, in a perfect world, get those decisions made today, but the board does have its May meeting as well. And typically the June meeting is reserved for either approving rates, final rates, or the board has it off. So either way, it'll be a shorter meeting or no meeting in June. So no pressure today. I think you'll hear a lot of information, have some good discussion. Yeah, if you can get to final decision today, great. And if not, we'll work to get there in May.
Thank you, Ali. And with that, I'd like to hand it over to Mercer.
Thank you very much. Good morning, everyone. Really excited to be here with you all and get some rare face time. Always a treat in today's day and age. And so we're looking forward to today's discussion. I think we've got a little bit over 2 hours to walk through round 3 renewals and sort of continue to hone in on final decisions for 2025 plan year. Like Ali said, whether those decisions are made today or in May, I guess will be determined based on how the conversation goes today. So if we could jump to the next slide. Just give folks a little bit of an overview for some of the content for the next 2 hours. As we typically do, we'll start off with PEBB's vision for healthcare in Oregon. We'll then move into an update on financials. So that section will include an update on the reserve fund, as well as the projected balance of that reserve fund over the next few years, an update on the composite rate, including the dollar amount that the PEBB benefit program is currently over 3.4%. We'll take a look at the current status of the plans as it relates to low-cost plan status, and talk through some levers that the board has in your figurative toolbox to get that increase down to 3.4%. Once we've provided that financial update, we'll move into section 3, which is where we'll get into some of the program change considerations for 2025. This will be a mix of a lot of items that board members you've seen over the last few months, as well as a couple of new items. And then in section 4, we will spend some time talking about weight management solutions and different support options available to members. And then we'll wrap on next steps and talk about what's to come in the next month or two as final decisions are made and final rates are approved. So let's advance to PEBB's vision for healthcare in Oregon. I'm not going to spend a ton of time on these slides. I know folks are pretty familiar with these three at this point. This first view and sort of vision statement really is sort of like a North Star of sorts. As board members, you continue to make those final decisions for 2025. Keeping this sort of high-level vision of the ideal state of healthcare delivery in Oregon in mind. So I'm going to jump to the next slide. This is the health equity strategic pillars. This is really a useful framework that can be used to really center equity for anything and everything decision related for PEBB, and really a way to keep PEBB's diverse membership at the forefront as discussion is had around some of these potential changes for 2025, and really a way to bring some structure to what is really a key part of PEBB's vision for healthcare in Oregon, which is to eliminate some of these health inequities and disparities that we know exist today. And then the final sort of stage setting slide, if you will, is PEBB's long-term goals. And so these goals, which I know folks are familiar with, are on the far right in that light blue. These are not siloed goals. These really are interrelated and reinforce each other. And many of these are addressed throughout the renewal process. Some are addressed elsewhere throughout the year in other work streams. But we do bring this forward at the outset of these conversations just to sort of serve as a refresher of sorts on what PEBB has determined to be long-term goals for the program. Any comments or questions so far? Okay, and with that said, I will hand it over to Emery, who will take us through the financial update.
All right, thank you, Andrew. So this slide 8, is actually an update of the RBC, or the Stabilization Fund, results. We did take a look at it based on the latest round of projections and premiums. And so this is our most up-to-date version of where you are. So taking a look at it, 24 is and 25, the Stabilization Fund balance is projected to be above the RBC target. So you can see there in the chart, the first 3 columns, lines. The purple line is your stabilization balance. The target is the box with the pink line going up. And so you can see the first 3 remain above the target. However, without any plan design changes and funding coming in at 3.4%, you can see for 26, the ending balance does fall below the target, and it becomes a bigger delta, a bigger deficit when we talk about 27. So the costs are based on the market trend rates, and market trend rates are expected to be higher than 3.4% limitation. So that's kind of the challenge that PEBB is faced with over the next couple of years. While essentially you can buy down the entire difference delta between the cost and projected funding, which is the third bullet there, $22 million of difference. That's fine for 25, but it does put you in the deficit position for 26 and beyond. And we have a couple other slides showing that. And so that delta does need to be made up, essentially, if you want to keep above the balance in 26 and beyond. 24, the legislature had appropriated $90 million out of the fund. Originally, it was projected for 25. Now they moved it up to 24. So it's a year in advance of where we were last time we had done the RBC update. And so with that $90 million transfer, that does drop the 24 balance sooner. And then we have a $9 million estimated penalty to be paid to the feds in 25 instead of 26. And so that does make 25 in a little bit of a worse position here. Go ahead, Shiva.
Yeah, just a quick question. Maybe this is a question for Ollie. Can you just share how we learned that the legislature planned to take the funds a year early?
Well, it would be a thank you note. We really weren't told. It was just a part of a late short session kind of piece of legislation that came through. So a legislative adjustment that was made to move it up throughout 1 year.
It brings into focus the lack of control we have over the stabilization funds and the utility potentially of use it or lose it approach to that.
Yeah, that's
a little bit.
definitely true. I think, several years ago, there was a lot of hesitation in reaching into, they call it a sweep, sweeping some various reserve accounts around the state. This one in particular incurs about a 10 to 15% federal penalty for taking those funds meant for employee benefits and using them for a general purpose, like the general fund. And with that penalty in mind, I think at some point, probably 6 or 7 years ago, they took that step, and now it's become almost like an annual or semi-annual kind of legislative directive.
For consideration.
Yeah.
Thank you.
So the money is going into the fund, that 3.4% limitation, it's essentially to fund benefits. So it's essentially part of the compensation for state employees. And any delta between that funding and where the claims come in, and in 2020, 2021, obviously with COVID, the claims were much better. And in prior years, the claims had been coming in below projection. So you've been building up that stabilization fund, and the legislature has taken money from that, which essentially is taking away essentially part of that 3.4% funding that is potentially, you could consider compensation, because that is part of the compensation for employees. And so it is going away over time. And there's been, I think one was over 100 million. I can't remember what another one was, 50, something like that. Yeah, so over $200 million has been taken away from the fund over the last few years. And so that is a rather significant amount of money, but yeah, and it has put, you've been building up the surplus, but it's been drawn down over time. And so right now you are in more of a, I guess, precarious position where the need's a little bit more immediate in 25 and 26, especially with healthcare trends the way they currently are and what we've been hearing from the plans. So that's an update on stabilization fund. We talked a little bit, if we go to the next slide, about the impact of buying down rates based on stabilization fund. This is actual illustration based on the numbers where, if you do buy down in 25, essentially that purple, and in this case it's 20.2 million, which is after the performance guarantee penalty payment, the trend guarantee. If you do buy down at 20.2 million, it does build up over time. So you still need to make up that subsidy in 26 and beyond if you don't make plan design changes or costs come down. And on top of that, the growth in trend, you can see you would need to either subsidize or make plan design changes, which is that light blue box. In 26, about 47 million. That's kind of like the growth in the delta between the growth in trend and a 3.4% limitation. And then again, if you do decide to buy down in 27, the deficit position that we were talking about from the prior slide keeps growing. And you can see the three elements there on the right that either needs to be subsidized or made up in plan design changes. So that's really the challenge and the amount that needs to be made up per year in order to meet that 3.4% limitation. Any questions before we move on? Okay.
Just a
Yes,
comment, I mean, again, this is before we make any plan design changes.
This is before we make any plan design changes. So yes, if there are like we do have certain options, where you can make plan design changes, which aren't necessarily cost sharing changes, and those do definitely help. And any way that you can reduce the long-term trend or the trend, does help. And that reduces the subsidies that you need. So it takes away from that $20 million, at least for 25. And makes it easier for the following years. And again, to show on the next slide, it's kind of like the graph of, if you do make that mix between, thank you. If we do make that switch the mix between plan design changes and subsidies, this chart kind of shows you the trajectory of the stabilization fund versus the target. So you can see for 24, we're at that point, but the decision for 25 can change how the slope is and where you are compared to the target for 25, 26, and 27. So the bottom line, actually, if you add GLP-1s, assuming it's $15 million, that's kind of without any benefit cuts. That's essentially what's going to happen to the stabilization fund. It's going to be essentially the lowest of these projections. At the very top, that's basically making all the $20 million differences in benefit cuts for 25. It does reduce the need for 26. It basically almost puts you right at the balance for 26, but you are kind of going to be you're going to be, I guess, having costs still higher than the 3.4% limitation in 26. So that ends up having the stabilization fund essentially get to where the target is. And then 27, you still need to make cuts in that case, assuming trend continues the way it is. But the other two lines, the pink and the green, are kind of like where we are. So status quo without any plan design changes and just subsidizing it is the green, so it's the bottom one. But the pink one is kind of like if you did half. So half benefit changes and half subsidization. It kind of puts you in a little bit better position, but does put you in a little bit, in a place where in 26 you would still need to make some adjustments in order to meet that 3.4% limitation and puts you below the reserve target. So that's some of the considerations as we go through the plan design changes here. Any questions, comments? Okay. This next slide was something that actually I think Sean was asking for from the last meeting when we were talking about the risk scores and the plan performance. And this one's measuring the members who were in the same plan. And for Kaiser, it's anyone in the Kaiser HMO or Kaiser deductible that's remaining in the same plan over the last essentially 5.5 years, from 2018 through June of 2023. So these are long-term PEBB employees, and you can see essentially the change in risk and the change in cost by plan. So the light blue on the left, or the blue on the left, that's the cost, the PMPM increases. And then the ones in purple are the risk score increases. There are a couple things to note. I think in the past we show rebates and admin. Unfortunately, because we're looking at specific members, we don't have the rebates that are tied to them. So this is kind of like an overstated. So some of the plans have definitely had bigger rebates over time. And so that does bring down some of the costs. Kaiser does not have rebates, so they're kind of on that true cost in this case. And also integrated care fees are not included for Kaiser. Some of those are on a relative basis. We could have estimated it, but we did for this analysis. But taking a look at pure claims and the difference between that and the risk scores. So really, I think to Sean's point, it's like the risk scores is maybe a proxy for how well your members are being managed over time. So I've said in the past, over time, it's usually 2-3% as you age. You can see these risk score increases are actually a little bit higher. So they, in total, for continuous PEBB members on the right, so you can see the risk scores increasing 5.2% per year. So that's kind of like the average. Kaiser's actually performing better than that. They're managing members to about 4.2% increases over time. Statewide is actually a little bit better than PEBB, 4.8. And then Choice and Moda, you can see, are actually at or above in terms of the risk score increases over time. And then the delta between that and the PMPM increases is kind of like how much the costs have increased over the risk. So how much more does it cost to manage that risk? And you can see Kaiser is actually pretty close. So they're kind of, the costs and risk are kind of increasing the same amount of time over time. Choice, Statewide, Moda, as I mentioned before, there are rebates that are being factored in there, and so those would actually decrease, but the delta between the cost and the risks are a little bit higher. So maybe the advantage is not quite as bad, or the efficiency is not quite as bad as what's shown here, but the costs are increasing a bit more than the risk in this case. So the efficiency of the plans may be over time managing those same members has been slightly eroding over the same time. But kind of longer term look at the members and how well they're being managed by the various plans. Yes.
So I just have a question to make sure I understand. So this is controlling for migration because these are people who stayed in the same plan.
Yes.
And then can we extrapolate from that unit cost went up
Yes.
compared to risk?
Yes. Unit cost went up more than risk. So, you know, there was that the Senate Bill 1067, which, you know, did provide some savings and help bring down some of the costs. But yeah, in terms of the cost, the unit cost for those members, some of it may be just, you know, the cost of services for like just office visits or, you know, facilities. Some of it may be new services, you know, new drugs, new types of services that just kind of making it more expensive to manage those members. But, you know, it's like over time, you know, the one on the left, you have to manage both. I mean, we talk about the risk of the members and how that impacts your trend. And you can see it's a big portion, at least for the continuing longer term members, which, you know, for PEBB, there's quite a few of those. But the number on the left is really compared to the 3.4%. And so you can see, you know, there needs to be stuff done over time in order to manage to that 3.4%. So that's why, you know, we're here today talking about some exchanges.
Yeah, my only thought was that to look at demographic shifts in the population over time. I know it's continuous enrollment, but maybe different types of demographics.
Or is it supposed to be the same members though?
It's the same members. Your mapping, yeah. But there's definitely people coming in and leaving. Yes.
So like, even like tracking changes in average age of the population over time, because continuous enrollment wouldn't necessarily control for that.
Yeah. As new enrollees come in and, you know, people retire, that does definitely help PEBB and bring down the overall cost trend. And PEBB has been growing. I mean, you're now over 60,000, which is,
Right, so this slide shows the same members aging 5 years.
Yeah.
Yeah, that's right.
yeah, I think last month we showed the overall
Right.
mix.
Okay, right.
Okay. So just to also kind of be a, you know, adjunct to this slide, we just wanted to bring back the next slide, which is kind of the efficiency of the plan. It's like, you know, I think taking this slide and the prior slide together and just kind of taking those 2 points and melding them together kind of gives you a better overall picture of the plan's performance. It's not just the managing the risk of the members, it's the cost of managing that risk as well. And while Kaiser's kind of kept their costs pretty consistent, it does cost more based on this efficiency analysis to manage those members. So essentially, you know, they're performing better, but it does cost more. So I guess you get what you pay for, you know, it's like, that's part of the overall equation. So we've been talking about the efficiency and how much it costs to risk manage that risk per member. You know, Moda is lower, but, you know, the risk of the members has been increasing higher for those who are continuous. And so while their efficiency might be better, the continuing members do have higher increasing risk than where, you know, some of the other plans. So that's kind of like, hopefully provides a more complete view of how the plan is performing. Okay. Now to what I guess what we're all here for is the financials for with the latest rates. So these next two slides are things we've shown over the last few meetings. So we do have each plan there on the left, the lines of coverage, admin fee increases, and then the rate increases with everything kind of baked in and the total premiums. So in terms of the admin fees, actually MODA did provide a decrease. So they did come back and provide some savings. So their admin's 1.5%. And then the current rate increases there on the right, statewide, the first line actually is now at 5.6%. So it is a little bit better than where we were. Choice, about the same, 10.5. Kaiser did come in at 5.2. And these are actually after the performance guarantee reductions as well. So there's a little bit for that, but not like maybe 0.2% difference, but that is baked into these. And then MODA's coming in at about 5.8%. And then Delta Dental is 5.4, and then Kaiser Dental came in with a reduction of 2.2. Willamette changed their rating to 1.5. VSP is about the same where they were before, minus 3.5, and then the standards just going to 27. So overall, the numbers are a little bit better, and you know, the overall reduction, you know, to the deltas now 22 million. I think we were talking like 36, I think, or something like that, 38 million before. So there definitely has been improvement since last month, and overall the premiums are $1.3 billion. We'll have a little bit more detail on the composite rates, but in a sec, but just kind of showing you the overall increases in the rate increases here. Next slide, please. And then the non-composite benefits here. So overall, it's DHS is 2.9, Weight Watchers 2.0, and you can see the numbers there. And the projected premium for Weight Watchers is based on engagement, and this is about $2.5 billion that's paid out of the stabilization fund and not the composite rate in this case. And there's more information in the presentation as well. Okay, next slide, please. Thank you. So we showed the rate increases, and one of the considerations, which I think leads into some decisions, is, you know, the low-cost plan for a majority of the PEBB members. A low-cost plan is a plan that's 10% or more lower than the statewide plan, essentially statewide plan. It's a little bit more legalistic than that, but so with that, if they meet that threshold, they get 1% contributions. In the past, over time, Kaiser Deductible, MODA, and Providence Choice have been meeting that. Unfortunately, MODA and Providence Choice do not meet that threshold right now. I think MODA last year did not meet that threshold, but the PEBB board did elect to use stabilization fund to reduce the rates in order for that members would get that 1% contribution. MODA and Providence Choice don't meet that threshold. MODA is pretty close, 9.8% below statewide, but Providence Choice is considerably lower.
And last year was MODA, it was quite close, right?
It was pretty close last year, yes. It was like 9 point, I don't know, it was 9.5. It was like between 9.5 and 10. So it was pretty, it wasn't a lot of stabilization. But right now, these two plans are not below the stabilization fund. So, you know, if we talked about using surplus to buy down rates, one of the things that PEBB board could do is to repeat what was done last year, which is to buy down some of these these plans that were low-cost plans to make them low-cost plans again. And so that members would not be disadvantaged by being forced to change plans or pay a 5% contribution versus a 1% contribution. So if you did do that, that would essentially be about $15 million in stabilization fund. It's actually closer to 16. Most of it going to Providence Choice, but it would essentially, you know, you buy down the rates, the amount of cost, you know, that you're paying for PEBB does come down, and so that reduces the delta that you need to do in plan design changes by to about $5.5 million. Compared to the 22 million. It does, you know, put you in a position where you have to do something to reduce trend or make up changes in 26, but it does help for 25 in this case. So, as we talk about some of the other plan design changes, keep this in mind. And let's move to the next slide, actually. The composite rate here. So right now, the composite rate are with the no adjustments is the bottom line. You're at 5.3% compared to 3.4. So buying down both choice and MOTA gets you down to 4.0. So you have to make 0.6% in either subsidies or plan design changes to meet that 3.4%. And so you can see that currently about $21 million above the 3.4, and then buying down gets you 5.6, just about 5.6. So I don't think we need to make a decision now, but just to kind of keep in mind, if you did want to buy down those rates, it would make it closer, and reduce the delta, some of the plan design changes we're going to be talking about later. We do have a recommendation. Mercer does have a recommendation. I know that you don't want to disadvantage members. I mean, forcing members to essentially change plans or have their rate increases by like what 400% is considerable. The members have been in the same plans for a long time. That kind of disruption. Yes.
And adding into that, it also creates less incentive for people to choose the lower cost plans, and we have seen migration over time to the 1% plans.
Yes.
So if there isn't that incentive between the 5% and the 1%, more people might choose statewide, which is more expensive, and over time that wouldn't help with the migration and bringing costs down. So I mean that's also a fact.
That's also, and you can see the impact of that migration if you compare the columns in the middle and the columns on the right. So the impact of the migration can be seen between the percentage change in those two columns. So example, for 2024, you were at 3.4%. After all of the migration, you actually saved over 1% as people moved to the lower cost plans. And so that migration is part of that 1% plan, getting people to the lower cost plans, and that does help PEB over time. So if that migration was to be reversed next year, it would probably, people move to a statewide plan is going to make it more difficult for PEB to meet the 3.4 next year. Yes.
Is the premium tax for 2025, is that increased?
No, it's just the same. Yeah, we just put it in there. I don't know. I mean, because we could take that out. The premium tax came in 2020, and there was special dispensation by the legislature so that the 2% wasn't applying to the 3.4% limitation, which is one of the few times the legislature has allowed, like, hey, we did something to you, and now we're going to let you take credit for it or not have to be harmed by that.
So just for just so that I'm understanding, just for the sake of discussion, in a lot of the rural counties, they mostly have two choices, which would be statewide.
I think choice is in all but 2 counties. So choice is there for most.
Choices in most of our rural counties, yes.
So choice currently is not close to the 10%.
No, they're yeah.
MOTA's within striking distance. So technically, just for playing this out and for a minute, in order for members to have a choice, MOTA would need to be bumped into the 10% in order to have like some option to get to the 1%, to have their 1% share.
Yes.
But their choice about what 1% plan you want.
Yes.
And then in the urban counties, Portland, the I-5, the Kaiser deductible currently is meeting threshold So if one was on Kaiser, one could keep Kaiser and switch from HMO to the deductible and get the 1%. And that would be kind of the only choice in the I-5 at this moment.
Yeah, if you want to, yeah, without buying down whether a multiple choice, Kaiser deductible would be the only one to talk about.
My question, because I don't live in Portland.
Yeah.
Am I able to do choice and MOTA in Portland as well?
Yes.
Okay, so.
Well,
So then
this
you-
in 24, yes.
So they would have maybe another option if.
Yeah, good point. They would have MOTA.
They may have three options to buy now,
Yeah.
to the 1% plan.
Yeah. Right now, there's one option for 25. You could make it 3 or 2, depending on how you want to
How we move it
buy
along.
down. Yeah, how you want to fund.
Yeah, that's what I was after. Yeah.
Okay, yeah. So rural, we may have 1. Portland may have 2 or 3.
Yeah.
For the
Well,
I-5.
right now, rural has
Right.
0.
Yeah, rural is, yeah, right now.
Just to be clear.
Unless, yeah, we don't make any moves right
No,
now. Rural has
We're all basically at every contribution of 5%.
Portland gains and rural gains, okay.
And that goes back to the stabilization fund discussion and back to, we did set money aside in the stabilization fund during the pandemic that has since been taken out by the legislature.
Right.
So,
And in 2021, the board did vote to essentially do a negative funding assessment to essentially reduce what was coming in. You can see that the increase is 0.8%. I don't know, some of you were here then on that decision. So basically, yeah, the board decided to, hey, we're going to give up 2.6% of funding in all future years to help the state in that case. Yeah, it doesn't carry over, but yeah. The board has made decisions.
I just, not making a position or a motion. I'm just wanting to understand the cards in my hand.
Yes, exactly. Okay. Any other questions, comments? Okay. So moving on, we kind of talked about this in terms of trying to achieve that 3.4%. The column on the left, the negotiations, we've talked, Joel, Tano, various other terms, talk to the plans about trying to, make sure helping PEBB meet that 3.4%. And then the 3 on the right, we also asked for ways to improve efficiency, site of care programs, lower cost drugs, and some of those have been brought forward. And we've talked about some of those options, and we are recommending some of those. And then you got the 2 harder decisions there on the right, benefit changes to stabilization fund. We talked about that, and trying to balance it out, short-term versus long-term. Stabilization funds, obviously short-term, less pain initially, but it does put you in a more difficult position in the future. But benefit changes, shorter-term pain and longer-term benefits in this case. And so you kind of have to balance those. Hopefully, the 2 on the left gets you most of the way there. Unfortunately, this year didn't or doesn't. And so then you have to use potentially all 4 levers to try to achieve that 3.4%. So some things to consider. And then on the next slide, this is kind of like a summary of the first 3 slides that Andrew mentioned, in terms of creating, keeping the changes in alignment with the values of the PEBB board and keeping the members and, the focus on where it needs to be. And so, these changes, we do want to make it longer term. We don't want to just like hit, it's like short term. It's like, it's that might, just quick hits that feel better. But, we're trying to figure out ways to make it longer term, understand why we're doing these recommending certain changes or doing certain changes to reduce trend over time and to, further essentially the quintuple aim, the triple aim plus DE providers. And then, some of the things that the board has done in the past, especially some last couple of years, is kind of align some of the plan designs bit between carriers. I think there's been benefit additions with statewide getting the massage benefit. There's been some ER copay changes to make it kind of aligned. And some of the things that we are talking about in later on do result in some closer alignment. So potentially Kaiser pharmacy copays, right now they are better, but aligning those with Northern Providence or even Kaiser deductible. Kaiser, again, this PCP specialist copays are lower. And so those are some of the things you can consider if you want to follow that alignment value. And then so our recommendation there is on the right. It's kind of like, we do want to, that's our recommendation, potentially strategically using buying down rates, keeping the members so that they don't have to change plans or, keep the contribution down to 1%, I think is a good, very good value to follow. And it does use stabilization funds. And then meeting the rest of it through whatever you can through like more efficient methods. And, if we can't quite get there, figuring out what kind of benefit changes are needed in order to just meet that gap. Andrew, is there anything you wanted to add?
No, I think that's a great preview. And for folks who've looked ahead in the deck, we get a little bit more specific with regards to that recommendation as well as an alternative option. But that'll come after we go through sort of the potential options to drive efficiencies through program changes, which we'll review next.
Okay. With that, the financials are done. So any other final questions before we move on? Comments? Okay.
If I may,
Yes.
just acknowledge, thank you for the work that it takes to try to make sense of what is pretty complicated for those of us who don't spend our days there. That's very helpful. And also the work that it has taken to negotiate and try to get us to where we are so that we have some feasible options now, I hope. I also want to acknowledge that board member Cheeky Flowers appears to have joined. Cheeky, are you with us?
Good morning, everybody. I am here. Can you see me okay? I'm having Teams issues as well, so I'm hoping everything is working today. Can you hear me and can you see me?
We can hear you.
We can hear you and we can see you. Thank you for joining.
Thanks, everyone. Good morning.
And with that, I think we can go ahead and move on into our next presentation. Thank you.
All right, sounds good. So let's jump to the next slide, please. And so in this section, we'll be going through some of the program considerations, some of which we've gone through over the past few months. There'll be a couple of new ones as well. But before we get into those, we did want to show you this slide on the proposed admin fees for Providence on the left and MODA on the right. As Emery mentioned, MODA, in a show of partnership, did reduce their proposed admin fee down from 2.9% to 1.5%. That does help in a couple of ways. These admin fees are baked into the rates, and so it helps bring down the composite. It also helps bring the MODA plan a little bit closer to that low-cost plan status. Still a little bit of a gap, like Emery just showed us, but nonetheless, it is a step in the right direction. So the way we've set up these slides is to show a summary for each of your medical carriers. And like I said at the outset, some of these you all have seen before. And so the way that we approach these is to sort of flag a couple that either are new, so items that the board hasn't seen before. You can see we've noted those bottom 3 rows there as new, or just items that we've talked about, but we think more discussion is required. But that said, obviously, if there are questions on some of these rows that we haven't highlighted for more discussion, please do raise those. I can give a quick summary on each of these rows to see if that creates any questions for folks, or if we uncover that actually discussion is required on such and such program change. And so with this first one, dispense as written, this was a proposed change that would require members to use a generic equivalent as opposed to a brand drug. Good savings associated with it, a little bit over $2 million. Those generic equivalents are therapeutic equivalents, and so they're just as effective and safe as the brand version of that drug. And so this change would save the member money. It would also save the plan money. I'll run through these and then I'll pause and see what comments and questions folks have. With the second one, this is re-looking at a current exclusion, which excludes hair growth medications from the plan. And the potential change or consideration here is to create an exception for members who are diagnosed with severe alopecia areata. Hope I'm pronouncing that right. The cost impact is negligible. It is a somewhat rare condition, is my understanding as a non-clinical person. And so that is one that we are recommending that the board approve for 2025. The next one around updating the value list of medications. The value list, just as a reminder, is a list of drugs on the formulary that are offered to members at no cost share. They are relatively low-cost drugs, and they're intended to support folks who are managing a chronic condition. And so this is another one that we're recommending that the board accept. There are some moderate savings associated with it, but it really is best practice to update the formulary along the way. And so that is another recommendation that we are putting forward to the board. The next one is around a fertility benefit expansion. I'm going to skip over that because in the next slide we'll talk about that in more detail. The doula benefit we talked about last time. This is a decision that hopefully board members are in agreement, sort of makes sense to approve for all the right reasons. You know, it provides an enhanced member experience, improves clinical outcomes, it reduces costs in the long term. And so that is one that we are recommending the board approve for 2025. And then we've got 3 new rows at the bottom. And with each of these, we're going to talk about these in more detail in a couple of slides. So I'll just give them a little bit of brief airtime, and then I'll pause for comments and questions. So the first one is around updating the formulary to exclude a couple of therapeutics classes of over-the-counter drugs. The savings are pretty small, but this would align with another change that's being proposed on the MODA side. So we'll talk about that one in a little bit more detail here. The next is around RX Savings Solutions. This is a third-party vendor that identifies savings opportunities for the member based on their current list of drugs that they're taking. And so it's an opportunity to drive savings for the member and for the plan. And again, we'll talk about that in more detail. And then the final one before I pause is an update to Providence's integrated fertility vendor across their commercial book of business. And so that one is more of an administrative update as opposed to a decision for the board to make. But we do want to talk about that in more detail in the coming slides as well, to make sure that you all understand how that program works. And it is driving a good cost reduction as well, about $2.5 million. So that was probably a lot, but I want to provide that overview. So I'll pause and see what comments and questions folks have.
I just want to make sure that I'm understanding. So when we saw the earlier slide and the reduction that would have to come in for between Providence Choice and Providence, it does not take into account any 2 to 3 make it here, right?
It does not.
Okay.
And a lot of these are like kind of like proportional between statewide and choice on this one, so it doesn't really change it.
The same gap.
Yeah,
Okay.
same, yeah, the gap's basically the same.
Okay.
And don't worry, you know, if you do vote to do that, I'll make sure the numbers work out.
The network change is not baked in?
It's not, it wasn't, no, it's not. I mean, I guess it could be baked in. But no, we didn't for this, no.
But yeah, I mean, it doesn't matter from the point of view of like the difference.
Not
But
really.
it does matter to the overall,
Right.
like 3.4% that we're trying to solve for.
Yeah.
Okay, so I think we can proceed to the next slide, which is where we're going to look at the fertility benefit expansion that I sort of glazed over, because I knew we'd get there here. So I'll just provide a little bit of context on how these proposed changes came to be. And these are very sort of granular proposed changes. So last year, Mercer did 2 analyses. One was looking at fertility care gap analysis, and the other was looking at covered services for gender affirming care. And so last year, a member submitted some feedback, and through doing some research, we determined that for this member who was seeking fertility services, their benefit was their pharmacy benefit was being eaten up really quickly because those claims were that were being applied to their accumulators were pre-rebate. And so they were not getting the advantage of the reduced cost of those drugs. And so that sort of kicked off one of these deep dive analyses around fertility. The other around gender affirming care was really sparked by House Bill 2002, which established some standards of care for gender affirming care. And so we have these 2 analyses, and what we've done on this slide is to summarize the proposed coverage changes. And you can see there's a couple for each of the carriers. And again, these are very sort of granular, but nonetheless important. And so I can just read through them quickly, and you can know we've got a cost impact on the far right. So for Providence, covering fertility services for those who've undergone voluntary sterilization, as well as covering cryopreservation for members going through gender affirming care. For MODA, creation of embryos using the intended parent sperm for same-sex couples. Also the coverage for those who've undergone voluntary sterilization, and also the cryopreservation for members going through gender affirming care. For Kaiser, cryopreservation as part of fertility treatment with donor tissue, cryopreservation, tissue in medically necessary situations, and then again, the cryopreservation for members going through gender affirming care. And so, this is a, somewhat difficult year to make enhancements that are adding cost, but we are recommending that the board approve these. These are high member impact areas for members who are going through gender affirming care or other marginalized groups, same-sex couples, and so there is an additional cost for these, but it is being recommended by Mercer that the board approve these changes. So I'll pause there and see what comments and questions folks have.
Sensible comment. So it's both an equity issue and puts us in compliance with House Bill 2002. Is that right?
So I don't believe that these are required by House Bill 2002, but they are additional coverages beyond those standards that were established in that bill. Yeah.
Do want to acknowledge the equity issue and that House Bill 2002 put in place a fairly broad framework for standards that that hopefully move us all toward aligning with best practices across the routes via which people who need gender affirming care or are trying to access it are able to actually get the care that they need. So I appreciate this.
Okay, if there's no more comments and questions, I think we can proceed. And so these were a couple of the other new items that I called out on the summary slide. The first is this over-the-counter removal for 3 therapeutic categories of over-the-counter drugs. And so we did review that list of drugs, and we don't have any concerns. We are recommending that the board accept this. These are very, very low-cost drugs. And so to give you a sense, you can see how many members would be impacted by this change, and yet really sort of small savings should these drugs be removed from the formulary. But that said, like I said on the summary slide, there is a similar changes being proposed on the MODA side with a little bit more savings. And so to keep the plans aligned, we are recommending that the board approve this one. But like you can see here, it's not really doing much to drive down the composite. And so I guess I'll pause there and see what questions folks have.
I just had a question, and Ollie, I don't know if it's more directed at you, but what we hear from members when we make this kind of like given here.
Like specific feedback from members?
Yeah.
For these?
I mean, do you see it having a large number of members being concerned.
It's a lot.
So this is Sarah. I'm a pharmacy team. I'm virtual today. I'm not sure I heard the question, but like Andrew mentioned, there's a lot of members who would be affected by this change. And what it would do is drugs that are currently being covered by the plan, they would be excluded and members would be directed to purchase the drugs over the counter. Most of this stuff is really low cost, like you can get it at Costco for under $10. But it could generate some member noise if they're used to being able to use their benefit for these products and now they have to buy them on their own.
So to make, this is Katie from Moda. I just want to say, when we moved to exclude over-the-counter alternatives years ago for the PPI products, so like omeprazole, we impacted a lot more members, and there was a lot of communication that went into it and a lot of education and letters sent. And at that time, there was a lot of feedback, I think, that staff did receive. And it was a great opportunity. And so, you know, I think we did communicate a lot more at that time. And then since then, the noise really has gone away and people really have learned about the alternatives.
Thanks, Katie. And one of those categories that you've mentioned, the proton pump inhibitors, is one of the ones on the list here.
Yes, so I was just speaking from Moda experience when we did this years ago.
So we can expect that members are going to feel it and notice and potentially communicate about it. It may be that the cost impact to them is not as high, but we can anticipate that. Yeah.
But it sounds like this change would maybe align the benefits that are in Providence a little bit more with what Moda is already offering, if these drugs are already excluded in Moda.
I mean, I don't know how, I mean, one of the things I know that has come up in the past is people's abilities to get things through mail order and other ways. And that's one of the things that you wouldn't be able to do once you just shift to over the counter, right?
Well, Sarah, I think you could still order them online, right? It wouldn't be through the mail order benefit through the plan, but is that right, Sarah?
Yeah, I mean, personally, I order some of this stuff from Amazon. It just gets shipped to my house. It's not part of the benefit, but you can order it. Absolutely. You know, Walmart, Target, any of those, you can get it mailed to you if you want to purchase it.
And mail order pharmacies do fulfill OTC with your prescription drugs too. Yeah.
So with this next item, this is another pharmacy one, and I'll make some comments here and then pause and see what additional comments folks want to make. This is a third-party vendor called RX Saving Solutions, and Providence is proposing integrating this into the plans. The way that this works is that RX Saving Solutions would receive a claims feed, a pharmacy claims feed from Providence. They would put that claims feed through their proprietary software, and the output of that software would identify any savings opportunities for members based on the drugs they're taking today. And so those saving opportunities are a little bit different than what PBMs are typically trying to identify. And so the way that if a savings opportunity has been identified, RX Saving Solutions will send the member an email letting them know, hey, how would you like to save $10 a month on your drugs? If you're interested, you know, click this button, at which point RX Saving Solutions would reach out to the prescribing provider. The provider would have to approve the change. The provider typically does approve the change something like 90% of the time. If it is approved, at that point, the member is good to pick up their new prescription. And so this is really, it's a proven solution. We've seen this be implemented for other clients that we work with at Mercer, and we know it works, and it is very member friendly in terms of not creating any additional burden for the member. They really make it easy for the member. The other comment I'll make is that Providence has proposed taking on the financial risk of this program, so there'd be no admin fee charged to that. And so, you know, if the program didn't have high utilization, there's no potential for PEB to be out additional costs. It's really just the savings that might get generated. Sarah, was that a fair overview? Is there anything you'd add based on your experience working with this third party?
Yeah, I'd say the big advantage of RX Savings Solutions, what it does is it helps members identify some of those savings opportunities that might not be obvious to them. Something like if they're using a generic, but for some reason the capsule is a lot cheaper than the tablet. And so by making that change, they can save money and the plan can save money. It also can alert them to maybe a drug that's in the same therapeutic class, but is a different agent. They're both on formulary, but one might be a lot lower cost to the member. So it's just kind of nice to find those pennies under the cushion, and consumers like it because it's easy to use and because they can save money and not just the plan.
Pausing for any comments or questions as folks digest that one.
Did Providence say how long they would absorb the administrative cost?
I don't think that there was a runway. I'm looking to Providence friends over there, so I think it was sort of indefinite with shared savings approach.
This is Kat from Providence, and our proposal is the proposal. So it is assuming that PEB agrees to roll out the program, we will absorb the administrative costs for that program because we do believe in the savings associated with it. So that is the plan.
Gotcha. Real time to good questions. Yeah.
Clarification of the proposition. Thank you.
Always good to be in person to have those kinds of real time combos.
Well, I've even had in the past pharmacists do that for me, and like she was saying, you know, when you use your RX card or you get extra $5 off, you really do feel like you win. I mean, it doesn't matter if it's $5 or $10, you feel like you've gotten a little better something. So, you know, I've had my pharmacist tell me, hey, you can get this in that form if you want, it's better. And, you know, same thing, cheaper. And so for me, I always feel like, oh, good. I only have an extra $1, but it's an extra $1 that nowadays I really do need. So.
Yeah, this is Gina, pharmacist at Providence Health Plan. And I just wanted to add to that, really, I think it gives members agency over their, medication costs, like you just had mentioned. We had great experience with our Medicare population. So definitely a population with multiple medications. And a lot of times it is these generic medications that can make a difference when they add up over time, if there are therapeutic alternatives. So really great member engagement as well as member experience in our Medicare population.
Thank you.
So I think if we want to move forward, this is a little bit more information on this change that I described a little bit on the summary slide. And so just as a reminder, this is Providence is integrating with Progeny across their commercial book of business. So Progeny is a third-party vendor that really specializes in fertility support for members. And so one of the primary ways that they do that is through concierge support. And so they're providing members with sort of a white glove experience as they navigate what is a very difficult care area to navigate traditionally. And in so doing, they're providing a better member experience, but they're also driving towards better outcomes. And so a higher percentage of IVF live births, a lower percentage of multiples for folks who are going through IVS. When there are multiples, whether it's twins or triplets or quadruplets even, there's a higher likelihood that those babies will be born prematurely, a higher likelihood of having a stay in the NICU. And so those types of outcomes are obviously good for the member. They're good from a plan cost perspective. And so this change does necessitate a change to the current plan design. And so today the benefit is set up as a $25,000 max on the medical side per year, and unlimited pharmacy benefit. Progeny doesn't have and doesn't administer annual maxes. Instead, they have a cycle approach. And so they have what's called a 1+1 smart cycle approach. And what that means is that the first cycle of the year is fully covered. If that cycle fails for whatever reason, the member is given an opportunity to do a second cycle within the same year. And that's an enhancement because oftentimes members can eat through their $25,000 medical benefit with the first cycle. And so if that fails, they're sort of out of luck until January 1st the next year unless they want to pay out of pocket. For a lot of members who are using these services, time is sort of the essence. There's a lot of members who are a little bit older, and so they might be eager to start that second cycle as soon as possible. There are some changes to the network, so this is a fully carved out solution, but fortunately Progeny has a really broad network, and so all of the existing providers in Providence's fertility network today are included under Progeny with the exception of one. There is a clinic in Vancouver, Washington that would fall from the network. And in addition to the existing ecosystem of providers, there'd be 10 additional clinics that would be added to the network. So that's Progeny. There are good savings associated with this one to the tune of about $2.5 million through those better outcomes and reduced waste in the system. But I guess I'll pause there. I realize that was a lot, so I'll pause and see what comments and questions folks have.
And we're not voting on this. This is just a change that's happening, right? So it's just more for us to understand it.
That's right. Yeah, that's right. Okay, I will move forward. We'll shift gears and now talk through the MODA proposed program changes. And so similarly, we've got a summary slide, and I'll give a little bit of a description on those topics that we've talked about in previous months, just to sort of jog folks' memories and see if any questions come up. And then similar to Providence, we have some new items, as well as some items we discussed, but more discussion is required, like the teledoc virtual primary care. And so the first one is around the clinic level attribution. This proposed change, so employees who enroll in the MODA plan have to select a PCP 360 when they enroll. And so this change would attribute the members, instead of attributing them to an individual primary care provider, it would attribute them to the medical home, to the clinic. And so this reduces a little bit of admin burden in the instances when that provider leaves the medical home. Maybe they find a new job, maybe they retire, but when that happens, it creates a little bit of swirl for the plan and the member and the clinic. And so by changing how the employee and the member is attributed to the clinic, it reduces some of that administrative swirl that gets created in those situations. And so this is not one that has a cost impact, but it is sort of an efficiency thing and something that we think makes sense to accept. The next is around teledoc. I'm going to skip that because we're going to talk about that in more detail. Nutritional therapy, with this proposed change, this would remove the requirement for a diagnosis to be able to use nutrition therapy. And so today in the plans, if you have a diagnosis of type 2 diabetes or an eating disorder, you have access to this benefit. This change would remove that diagnosis requirement, make it more accessible to the entire enrolled population. Doula, we had talked about this one when we went through Providence, so I think I'll skip over that one, as well as the fertility benefit expansion. This one aligns with that slide that we had showed you in the Providence section. And then we've got a new row here for Kindbody, which is another fertility support vendor, which we'll talk about in more detail in the coming slides. But before I move on, I want to pause, see if there's any comments or questions on some of these items that we were planning on presenting on again. Okay. We do have another summary slide for MODA. And so these are all items that we talked about last month and the month before, but we do want to talk about, in particular, the site of care programs. And so these first 4 rows are site of care programs. So we've got home infusion, musculoskeletal, advanced imaging, and gastroenterology. We are recommending that the board approve the first 3, but not the 4th, not gastroenterology. And so the way that these site of care programs work, the provider would submit a prior authorization request. That request would then be evaluated along 2 dimensions. It would be evaluated for the procedure itself, and then it would be evaluated based on the proposed site of care. And so for the first 3, there's already a prior authorization for the service itself in place today. That's not the case for gastro. And so that one would be a little bit more disruptive because we'd be introducing that prior authorization for the first time for those services. And the estimated savings with that program are more moderate. And so we are recommending that the board decline that one. I'm going to pause there and just, there's likely some questions around site of care. So before I move on, I'll just pause and get folks' reactions to that.
Could you give a 2-line summary on what the site of care evaluation is doing and looking for?
So yes, so when the doctor submits the PA, they're only submitting 1 PA, and then there's the two components that MODA is evaluating: the procedure and the site of care. And so MODA is looking at appropriateness for the site of care based on the recommended procedure. And they are allowing for exceptions for more high-cost sites of care where it makes sense based on some justification that the provider has provided. If that justification is not there, MODA will say, well, no, it's not approved at the hospital. There's actually an outpatient ambulatory center or imaging center that is more efficient. And so that's the recommended site of care.
Thank you.
And it's not retroactive, like after it's happened, they send the bill and then they're like, oh, I don't want to pay that bill. They're saying this is proactively, you know, we need approval to go do this thing. And they're like, no, you need to find a different place.
That's right. Yeah, that's right.
But they advise on the correct place. They don't say, no, now go figure out another plan, right?
I believe so. Is that right, Erica? That's my understanding of the program. Yeah.
Okay.
Thank you.
All right.
Okay.
For this next one, outpatient diagnostic labs, this is one that we've gone back and forth with a little bit on MODA. Ultimately, our recommendation, we landed on declining it. This change would, so today labs are covered at 100% in network. This change would allow for that plan design and full coverage to continue only at Quest labs. And so there are not a lot of Quest labs in rural parts of the state. And so this one would be disruptive for a large percentage of the enrolled population. You know, we did explore, is there a way to do some sort of custom configuration for folks who are outside of X miles, you know, away from a Quest lab, and there really isn't a way to configure in that way. And so while there are good savings, we think it's just going to be too disruptive, and so we're recommending a decline in that one.
Acknowledge that equity impact specific to rural populations who have limited options and wanting to make sure they have the broadest possible options for getting labs.
So just to be clear, when we're talking about a lab, we're talking about a place that you go to get blood drawn or this sort of thing, and then that's the place where they analyze it, as opposed to going to a place, getting your blood drawn, they ship it to a place where its analysis is done, and that's the lab.
That's right. And then those results are sent back to your primary care physician to have that follow-up discussion on the results. But yeah, that's right. Yeah,
So it's the former.
It's the former. Yeah.
Okay.
Yeah. With the next one, increasing the brand drug copay is one we're recommending decline. This was one that was proposed a little bit earlier on in our renewal cycle. And we'll talk through options to get to 3.4% here in a couple of slides. So I don't think I'll make too many comments on that one. The over-the-counter alternative program, this is a proposed change that would remove non-steroidal anti-inflammatory drugs from the formulary. And so ibuprofen, drugs of that nature. These are drugs that, similar to the Providence over-the-counter change, are readily available, various retail locations, online. And so we are recommending accepting that one, and the savings generated from that change would be about $230,000.
Is that a lot of folks too, or?
Hold on one second. Let me navigate there, and I can tell you.
I'll say the one thing with these medications is they are acute in nature. We typically take them non-chronically. I know some of us take them more than we.
It depends on the condition. There's a lot of people who use NSAIDs regularly for conditions like arthritis, but sometimes they are in a acute condition. And Moda can correct me, but I think this program, it excludes some versions that are prescription only. So something like ibuprofen 600 milligrams would be excluded. You can't buy a 600 milligram tablet over the counter, but you can buy the 200 milligrams into freedom.
Thanks, Sarah. I believe that this recommendation excludes all, including the Legend products, similar to the proton pump inhibitors and the other agents. So this would be all the ibuprofen strengths. So if you do get a prescription for the 800 milligram ibuprofen, the idea would be that you would fill the over-the-counter 200 and take 4 of those.
I would say most pharmacists would be familiar with that type of benefit design and could easily direct people to the over-the-counter option.
So I don't have the estimated member impact in front of me, but maybe Emily, if you wouldn't mind looking through our carrier response workbook and seeing if you can identify that and maybe put it in the chat, that'd be great.
I'm sorry, I don't have that right. I can't, so I appreciate that. Thank you.
Okay, and this next one is for the Costco 6 for 6 program. This is a program where members can fill their value tier drugs. Those are these no member cost share drugs for chronic conditions at Costco for a 6-month supply. And so this is largely a convenience things for members. It's not really driving savings per se. These are very low cost drugs, but it is a nice benefit. You don't have to be a Costco member. You know, I did read recently that they're starting to check Costco membership at the food court, which is unfortunate for a lot of folks because the food is so cheap. But that's not the case for the pharmacy. You can go in, you don't need to be a member. And this is, you know, there's not Costco's everywhere across the state, but there are a good chunk. And so for members who live close to them, it could be a nice convenient addition.
And sorry, I do believe that it can be mail ordered as well. So even if you don't have one in rural parts, it also can be mailed to you.
The Costco 6 for 6 program?
Oh, just kidding. No, apologies. Takes a village. Sorry to interrupt.
I want to acknowledge that 6 months of a medication that someone is taking chronically that they're stable on can make a big difference, especially for people who are taking multiple medications and could be at the pharmacy every week or multiple times a week picking up medications because they don't all fill at the same time.
This is neither here nor there, but there's also a emergency preparedness component, you know.
Yep. Oh, look, his new role. He came over to our side. This is John too. He's the fire marshal. I got a fire chief in the house.
So let's advance to the next slide. This is an optional program for the board to consider. This is another, like Progeny, a fertility support vendor that really, similar to Progeny, provides high-touch concierge level navigation and advocacy for members going through a fertility journey. Unlike Progeny, Kindbody would be in addition to the existing Moda network of fertility providers. And so, but that said, if I'm a member who's enrolled in Moda and I call Kindbody to have, you know, some assistance being navigated, they will refer to non-Kindbody providers because Kindbody actually has their own proprietary clinics. but they're not necessarily going to steer everyone to those clinics. They will look at where you are and steer you appropriately.
Andrew, can I ask a question about one? Under this proposal, does that retain the 25,000 annual medical max?
It does, yeah. This one would not require that program plan design change that was laid out in Progeny. So it does create a little bit of a disparity in plan design.
Yeah, so I just wonder, like, are we potentially said there could be some potential adverse selection in terms of when members are assessing what benefit, you know, the 1+1 smart cycle approach versus a $25,000 medical max on a benefit. There's a difference there in what the coverage actually is.
There could be, yeah. I think that's a good point.
Yeah, with Time Body, because they own their own clinics, their pricing could be better than what you could get like through other clinics as well. So there's some advantages with that, making 25,000 go further.
Yeah, that's a great point, because it's not that straightforward of a calculation that an individual member could make. You know, comparing a 25K medical versus 1+1 cycle.
Yeah, just noting
Yes,
that
totally.
it's different.
Yeah,
It is
yeah,
different.
yeah, that's right.
And Andrew, we could see if we can administer the 1+1. I was not aware of it.
Yeah. Okay, that's great. Yeah, I think that's a good idea to take a look at that.
Yeah.
I was going to ask if you or someone else in the room was able to take that next step and say, how would one compare, or how do those compare? 25,000 maybe is only one cycle, or maybe 25,000 is 3 cycles, so the 1+1 would not. Is there anybody who?
I think, Mercer, I think we could definitely look into that. I mean, I know there's research on sort of average cost of what one cycle would be. I think it's typically quoted close to 20K-ish.
One of our fertility leads said that 25K is approximately one cycle.
Yeah. Okay, that's helpful for me.
One other thing that I noted, because we had someone in MODA actually who was asking questions around their fertility benefits recently, and what I saw in the open enrollment is that there is a separate comparison of the plans around fertility, and that was not true in 2023 and was true for the 2024 plans. And I do think that should continue so people can look at that across the plans.
Thank you. That's a great idea. Thank you.
And this is in addition to, correct? Yeah. What you're saying. So, to me, if I have another choice and there's a savings to us, it's, I know I have family right now that went through, several of my family members that went through this, and there's a lot of research as an individual when you do this that you do personally. You don't just go, hey, tomorrow we're going here and doing this. And so if we have something else that somebody can get or use and they're in an area where they might not have an ability, something is better than nothing for our people to have and to be able to use. So that's my 2 cents.
Yeah, I agree with that.
It's gotta be such a scary time, right?
Okay, I think, not seeing any other comments or questions. If we want to proceed to the next slide, this is one that we have talked about previously, but there was robust discussion, and so we thought we'd bring it forward and talk about it again. And so the proposed change here is to add Teladoc virtual primary cares to the MODA network of medical homes, and so essentially enhance the panel of primary care providers that are available to MODA members. And so, from a rural member perspective, this could be a nice addition. So I don't have the percentage in front of me, but most of the existing primary care providers in the MODA network have virtual capabilities. Not all, but many. However, Teladoc has a really high percentage of providers who are identifying as BIPOC. And so adding Teladoc as an option is essentially infusing the network with more diversity, not only for rural members to choose from, if it's important to you as a member to achieve congruence with your primary care provider, but really members across the state. And so the other consideration around this one is, should the board approve adding Teladoc to the network, there's an option to allow members outside of Oregon to now elect the choice plan if they are enrolled with a virtual primary care provider through Teladoc. And so I don't think that, and Emery, keep me honest, members outside of Oregon today don't have access to the low-cost plan. They have the Providence statewide plan available to them.
In some rural counties, some counties close to the border, they actually do. But it's like, yeah, but like, for example, like, I think Mona was saying, it's like if you have, one of the issues is with dependents that are going to college out of state, right? And so getting access to that network where you get the lower cost sharing is an issue if you don't first go through a primary care medical home. And so this would give those members an option, a way to get into that lower cost plan or get the lower cost sharing and the family remains in that lower cost plan in that case.
And we see that the universities too, when people are on sabbatical, they don't live in Oregon.
And other employees, I think, right, who are live
We
outside
now
the
have
state.
people who don't live in Oregon.
There's a lot of people who,
I was gonna say, for us in DOC, we have two institutions, one in Umatilla and one in, well, we have three, one in Umatilla, one in Pendleton, and the one in, right on the Idaho border. All three of those have medical homes in Oregon. 35% of my staff work in Washington. If they choose, Providence choice, they just have to drive across the border to the medical home. Now, we have tried several times to get a home in Washington. I know it's still in the works, but they're absolutely able to, if they're that close, to pick up that plan, which Portland, Vancouver, I mean, the same there, state workers, if they wanted to travel to a home, would absolutely be able to get that 1% plan. So it just depends on.
I was going to add for the motor plan a couple of things. We do have medical homes in Idaho and Washington on the border.
So for MODA,
Yeah.
because I know you said statewide, but for the choice plan, but MODA as well. If you have homes there, then again, yeah.
They're on the border areas. Yeah.
Yeah, so we have, partners in the Boise area and right over that border that members in the MODA plan can use those medical homes because we do know that a lot of people in those rural areas do go over into Boise and Idaho for their care. In addition, on the MODA plan, we do allow out-of-area dependents on the plan. As of right now, if you're a subscriber who lives out of the area, like if you live in Montana, then you wouldn't be eligible for the MODA plan. But if you're a subscriber who lives like in Portland and you have dependents who are going to school in Montana, then you could still choose that plan.
Okay. In that circumstance, like the Montana employees, for example, and Cindy, I'm kind of putting you on the spot, but I think we've heard from those types of members who say, why don't I have a low-cost plan available to me? And that's something that comes up, and it's not a huge percentage of the population. And I don't have it off the top, maybe 1 or 2%, but nonetheless, there are folks who raise that issue and say, I don't have access to this 1% plan. I have to be worth 5% of my deduction.
So this would give them access to the 1% plan, adding Teladoc, not just for the dependents. Can you also just go back over cost, because I thought this had a cost associated with it on the overall plan, impacting the 3.4%, but it doesn't show up on this other sheet we were looking at. It says, yeah, now it says negligible.
Yeah.
And can you just?
Yeah, so there's a fee, there's a capitation fee that would be paid to Teladoc based on any employee who elects Teladoc to be the PCP 360. It's $11 per participant per month. It is higher than the capitation fee that MODA is paying for most medical homes, which is usually in like the $5 to $6 range. But it is a per engaged employee payment model. And so to the extent, if this were introduced and it's not resonating, a lot of folks are not electing it, then it's not paying for it.
Thank you.
I want to acknowledge the importance. Oh, sorry, Emily, please.
Oh, yeah. I just wondered, is there a distinction between border states, like access to care for border states like Idaho and Washington versus like at OHA, we now have employees that live in New York, California, like the southern states. So is it all the same?
No, so, and I probably should be the one telling how PEB works. So please correct me if I'm wrong, but I think it depends on where you live, your zip code of where you live or where you work in that county. And depending on what county that is, you get access to certain plans. So for MODA, there's certain plans, certain counties outside of, the Idaho border, Washington border, and I think Choice as well. Well, yeah, I think Choice as well, but you get access to those. But if you don't live or work in that county, you don't get access to it. You're only in the statewide. So it's dependent by the county that you get attributed to, or like your location is. So in Montana, there's no. If you're working in Montana, and in that case you don't get those. Well, it's dependent on your employee, I think. So if you're in Montana and you're working as an employee remotely, then you only get statewide, because all the other plans don't. You're not eligible for those plans because based on the county that you're residing.
And Ollie, so this would mean PEB, like, let's say we voted and said, yes, we're going to offer teledoc. It means that MODA would then show up for those folks who do not live in Oregon. I mean, we're not talking about border areas, but people in New York or wherever. Is that right?
Would that require system change?
No.
It could, right? Yeah. So I think there would need to be, Again, I'm speaking out
It would be like
PEB.
I don't know. I mean, it's something that I've looked at many times because, it's like, what's the lowest cost plan for the folks who are in OUS, and they have to put in their zip code, and they have access to certain plans based on where they live, right? Because they only get one plan as the low cost plan if they're in higher ed. And we've also noticed, and we've talked about this on the PEB board, like some of the dental plans like Willamette are available statewide, even though there aren't providers statewide. So we want to make sure we're communicating with people so they know they don't sign up for it in Curry County and then they have to drive like super far to get access. So the medical does restrict, whereas the dental doesn't, right?
Well, I want to say I think the dental, the Willamette that's the way it was. That's the way it's been. It's like, it's always been like a statewide. So the county access has been statewide in that case. I don't know. I think it's a legal thing. Yeah, people want to drive there, but I think it's a PEB. You choose. The PEB board has voted to allow. PEB board has voted to allow plans to expand their access area. So I think with Kaiser, I think it's the most recent where they moved into lane, and there was a vote to have Kaiser as part of lane. So I think if MODA were to be parked beyond just the counties that they're currently in, there might need to be a PEB board action taken to allow that to happen in this case. And there's also systems issues. But I do think there probably needs to be some sort of action, but then again, I'm the actual on the systems.
Yeah, we can follow up with more information.
That would be great.
So just to clarify, so if we hire employees that don't live in Oregon, what options, do they just have the one statewide option? Okay.
Yeah, and we've heard some complaints about that.
Yeah.
I'd like to acknowledge that since COVID and since remote work has become such a standard, I think we can expect the number of remote employees to continue to rise. And it's something that we and our partners need to be taking into account as these plans evolve over time, that we need to do a better job of thinking about them as we're designing benefits and making care accessible, including through tools like teledoc.
I believe PEB now has members in every state.
Yeah, that's a good point. Yeah, yeah, right.
There would be a little bit of a communication challenge, Siobhan, similar to what you were saying around Willamette, right? If you're an out-of-state employee and you're shown this option, there needs to be very clear, you will have to select a virtual primary care provider.
Yeah, that's something that will have to be done. And then, as you said, it's per month per member. And then at that point, it's a with these three here, depending on what I'm looking for, it's X amount to the plan. And you said this is a little more than a standard medical home.
The application, the $11 is, $11 is.
More than a standard home. Like for me, I'm part of the standard home in Hermiston. So every month there's a $5 fee that's paid for me to be part of that home. And then when I go see the doctor, X. With this one, per month per member, it's an $11 fee. And then if I log in to say hello to the doctor, it's whatever the fee is. There's nothing extra on top of that.
That's right. Yeah. These are essentially the allotted amounts. It's like a contracted rate for.
Right. No. Yeah. And I know every time I go see Mike, which is very few, but every time I go see him, it's always the same $92. I mean, I don't think it's changed for a couple of years. So just something to, you know, and so this becomes your primary doctor. It's just not something you do every now and then. This is the person you go see. If you want to change, then you have to change. You know, it's specific changes after that. Okay.
So just for the sake of the decision potentially today, I think it's worth pointing out is like a teledoc, telemedicine home, like, yeah, if you, for the bulk of our members, if you take this option and you live in Oregon and then you have an appointment with your doctor and the doctor is like, yeah, we're gonna need to take some blood and we're at, you know, someone actually is gonna need to see you in person to take a look at this, whatever. That's pretty easily dealt with within the system. It's a different question, I think, about like external employees. That feels like a separate discussion of the consequence of that, which is it's just like an option, but we would talk about it. I would rather talk about that a little bit later because there's some different things to unpack about like where would they go if they needed to actually have someone go look at something and whatever, and how would we deal with that? And is that still a low cost plan because you can't control those costs and so on. So that I feel like those are slightly different conversations perhaps that be had next meeting. But for the moment, the general idea of teledoc access in rural Oregon for the bulk of our members seems fairly straightforward.
Sorry, I have an equity question that I think is exciting to think about. So like our Marshallese members in Oregon, like, so with teledoc, and I don't know how to articulate this, but there are certain Marshallese physicians, but they're not in Oregon, they're in Arkansas. So is there a way to explore partnerships, like, you know, in the name of culturally and linguistically appropriate care? Or like, you know, we know that the top 9 states in the country that have high Asian American populations, you know, maybe, I know, for example, Hmong community, there's Hmong mental health providers that are really high quality in Minnesota. Like, is there a way for us to explore those types of partnerships?
Yeah, absolutely. I mean, we can explore a lot of out-of-state kind of employee and access. I mean, I don't know about for this renewal today, but yeah, we can make that more of an all-encompassing kind of
Oh, that's exciting.
pursuit. Yeah.
One of the foundational efforts in these telehealth companies for a long time ago was to have the internal administrative machinery to help their providers have licenses in many states.
Oh.
So it's not like if there was somebody good somewhere that if they were a teledoc, they would likely be licensed in those states. So I can't imagine them having a model where you couldn't access somebody you would prefer. That, unless they've changed their model in the last year. I've actually drilled into their product in the last year, but I would think that would be something that would even be better developed.
I mean, the diversity numbers are far higher.
Yeah.
In general.
Yeah. I mean, they've been working on developing from more that urgent care kind of transactional business to something more like true primary care with a bunch of caveats about how you listen to the lungs and how you do the blood tests and how you integrate with other levels of care, which still could be worth exploring. But I think from the network management, that was one thing that they were planning to bring to the table.
Thanks for that.
I'm wondering if this might be a good point to do the 10 minutes. After this, we would shift gears to talk about Kaiser. Should we do, yeah, let's do Kaiser. Okay. So,
Oh yeah, this last slide, and then let's go ahead and take a break.
all right, sounds good. And these really are two items that we've talked about, and so this will probably be pretty quick. The first is the doula benefit, and then the next is the fertility benefit expansion, which corresponds to that slide we talked about at the beginning of the presentation around gender affirming care and providing support to those folks. Any questions or comments on that slide?
All right, thank you very much. Let's go ahead and take a 10-minute break, and we will return at
10 minutes.
Yeah.
He's like, oh, I gotta
Gotta rate it, the answer, and Ray, we're getting started.
Welcome back, everybody. Go ahead and come back to it. There's been a lot of information already, and there's a bit more to come. We may, if it turns out that the time it makes the most sense, we might go ahead and use the rest of today's meeting to round out this conversation and defer any conversation about the RFP to see how the time goes.
Okay.
And whether we'd like to spend a little more time with this conversation. I'll get back to you.
Sounds good. And so we're shifting gears a little bit with dental and vision and then some of the other ancillary coverages. And to the extent that board members are ready to vote on any of this, that is certainly an option. We have Emily Fuller from our team who is dialed in. And so Emily, hopefully you can hear us okay. And I will hand it over to you.
Yeah, I can hear you. Thank you. Can you guys hear me and see me? Great. Well, thank you. Sorry I couldn't be there in person. I was very bummed out that I couldn't go down there this time, but next time I'll be there for sure. So yeah, I'm going to quickly go through the dental and vision renewal. Maggie, if you want to go to the next slide. All right. So you guys probably remember this slide from last time. So again, I'll start with Delta Dental on the left in that green box. Their status quo cost increase did go down a bit from last month, from 6% to now it's at 5.4%. This represents a $400,000 decrease from last month. There's no change to the admin fee from round two, and they're still increasing, which is still increasing from $6.67 to $6.89. So if you just look down below for the plan design changes, so as I mentioned last month, they are proposing to add extra services for members with intellectual or developmental disabilities. And this comes at a negligible cost impact. And so Mercer is recommending to make this change. And then moving to the middle box there for Kaiser. So Kaiser's cost increase also came down a bit, moving from 2.6% to a 2.2%. This represents a decrease of $90,000 from last month. And then there was no changes to their admin fee, and they are still increasing by $1 from $4.75 to $5.75. This represents a 21.1% increase. And so Kaiser's proposing a change to the night guard and athletic guard benefit. Currently, their night guards and athletic guards are covered at 90%, with athletic guards being allowed once per year and night guards being actually having no time limitation. So this benefit would change both the night guard and athletic guard benefit to be covered at 65% with no time limitation, with no change to the limitation for night guards. And then so they would still be covered at once per year. And then the night guards, I'm sorry if I meant the athletic guards would still be covered at once per year. And then the night guards would be changed to being covered once every 5 years. And so this change is estimated to result in a savings of approximately $61,000. And as I mentioned last month, because this does align closely with what we see in the industry, with night guards typically being covered at 50% every 5 years, Mercer also recommends making this benefit change. And then on the right there, we have Willamette Dental. Their cost increase actually was coming in at 3% in round one, 1% in round two, and now due to more claims experience, it is increasing to 1.5%. And so this represents a total of $216,000 increase. And no changes to the admin fees, and there was no plan designs being proposed. And it is Mercer's recommendation to accept the status quo renewal. So does anybody have any questions on dental before I move on to VSP?
So I do have a question on, so the changes to Kaiser, I mean, the changes are quite, it's a big change for people who have night guards, because right now you're saying that they could get it anytime right now in new night guard, and there's not a limitation, but that's gonna go to only one every 5 years, is that right?
Yeah, that's correct.
Okay, and it's gonna increase quite a bit in cost. And you're saying that aligns with industry standards. How does it align with Delta and Willamette Dental?
So currently Delta covers night guards at 100% up to $150. So if you think about a night guard, typically they cost about $300 to $500. So it actually paying about, depending on what your provider is charging. If your provider submits a claim for $300, then I guess it would be 50% because you would get it up to $150.
Okay.
And then Willamette, I'm sorry I don't have that one at right in front of me. I'm not sure if somebody else might know that one off the top of their head.
Hi, this is Tiffany from Willamette Dental. Night cards are covered with the office visit copay. So it's just the $10 office visit copay and they're covered in full.
Okay, thank you.
But it's one every 5 years, right?
Someone was saying in the room, Greg, you were saying it for Willamette, you can only get one every 5 years.
How often can you get those, Tiffany?
Let me confirm the limitation and I will type that into the chat box here in just one moment.
Thank you.
Thanks.
I don't have a chat box.
We'll share the chat box. We're looking at it.
I can see the chat box too if she puts the answer in there. Were there any other questions on this one? Okay. So would you guys like to make a vote on these right now?
That was Emery.
I'll take that as a no.
Well, it's worth asking the question. Would we like to vote on the dental questions now in a simple form?
Sure.
Anyone? Is there a motion to vote on the dental questions here?
I can make a motion if you'd like to vote on the, I guess we can make the motion to vote on all three as recommended by Kaiser.
And this is Kimberly Hendricks. I'll second that as presented.
So the motion is to accept the Mercer recommendations on all three renewals as submitted or not. Am I correct?
Correct.
Yeah. Okay.
Can we have a discussion? So I'm asking if we can have a discussion about the motion now, because so the thing that I would be concerned about with Kaiser, I mean, the cost impact is really minimal, but it's a big change for folks, and I don't know how many people it would impact. So curious about that.
Sure. Ask about that, and Kaiser, I don't know, Safari, if you want to address it.
I don't remember the impact. It was very, very small.
It was so 750 people had claims for night guards last year.
750.
Yeah, there's like 20,000 members. So what's that, like 3%?
And they're suggesting that members who wanted a less expensive option could use a certain over-the-counter night guard that the Kaiser dentists have been recommending.
Yes, that's correct.
It's about, I think, $20 to $25, right?
It's not fun to get a night guard.
No.
Yeah.
It's not a great time. And then, like, they last.
They do.
You know, like you wouldn't want to do it. I wouldn't want to do it every year. So like, I guess someone really wants a new guard, I guess, every year, but relatively, it seems like they would last for, they definitely last several years, but.
Oh yeah, the custom-made night guards do last quite a long time.
You know, your shoes if you lose it.
Right.
Yeah, or your dog chews on it.
Oh, you're done. That's probably the two main causes.
Yeah.
Any more discussion on that motion at this time?
Willamette's limitation is once every 2 years.
Okay. All right. With that, I will open the floor to a vote. Siobhan?
Yes.
To accept the Mercer recommendations on dental. Cheeky Flowers, are you present?
We can't hear you. Chicky.
Second time, maybe.
Oh.
I vote yes as proposed. Thank you.
Thank you, Cheeky. Greg?
Yes.
Yes. Sean?
I vote yes.
Yes. Emily?
Yes.
Kimberly?
Yes.
The motion carries and the Mercer recommendation is approved.
Great. Thank you.
Thank you. Let's go ahead with the VSP, please.
All right, great. So yeah, we will move to VSP here. So no changes from what I presented in round 2 to round 3. As a reminder, there was a decrease of 400,000, representing a 3.5 reduction that Emery did speak about earlier. VSP recommended a 4-year rate guarantee for the basic and plus plan, keeping the admin fee at $1.15. They did provide 2 options that you can see here. The first is to increase the contact lens allowance on the plus plan by $25 to match the current frame allowance, which is $250 or $225, excuse me. And so the projected cost impact for this option would estimated to be 110,000 or a 0.95 increase. And then the second option on the right there is to increase both frame and contact lens allowance on the plus plan, increasing them both to 250. The cost impact for that change would be 3.7% increase. So one thing I didn't mention last month is that the plus plan is actually a buy-up plan, and this means that the member pays any additional cost above the basic plan. So the changes made to this plus plan do not affect the 3.4% composite rate. So with that, Mercer is actually now recommending to accept the option 1 to create equity between the frame and contact lens allowance in the plus plan. Is there any questions on this, or would the board like to move forward with a vote?
I will make a motion that we move forward with a vote to support plus plan increase option 1 as recommended by Mercer.
Second.
Any discussion of the motion? Being none, let's go ahead and take up a vote then to accept the Mercer recommendation and accept option 1 on VSP. Siobhan?
Yes.
Cheeky?
Yes.
Emily?
Yes.
Kimberly?
Yes.
Greg?
Yes.
Sean?
Yes.
The motion carries. Mercer's recommendation is accepted. Thank you.
All right, so moving to the supplemental, we have 3 different plans here. Next slide. Okay, yeah, thank you. So the first 2 that we have on this slide are ASI Flex and Benefit Health Solutions. There are no changes from last month. ASI and Benefit Health Solutions have no plan design changes. There's no increase for ASI, and BHS does propose a 2.9% increase in rates. Mercer's recommendation is to renew both plans for 2025. Any questions on this slide before we move on?
And these don't impact the 3.4%, correct?
Correct.
Should we go ahead and talk through the WebMD supplemental program before we proceed with the vote?
Sure, yeah, we can go to WebMD on the next slide here.
Thank you.
Yeah, so I'll quickly go through the renewal. The WebMD is proposing to keep the annual rate of $150,000 with no plan design changes for 2025. This annual fee is split between the 3 plans, and it will stay the same regardless of the number of eligible members reported in each month. And the proposed contract is for 1 year with a 3% increase in January 2026. So as you can see here, it's Mercer's recommendation to discontinue the WebMD program. And as you may remember, this decision is based on findings from the review that Mercer did on WebMD's user experience, how they support health equity, and the utilization of the program. So these findings determined that based on their low utilization and the fact that there are duplications of most of the services provided by other carriers, Mercer did recommend discontinuing the program. And as you may recall, Dr. Neldner did go through the findings last meeting in great detail, and it was determined at that time that the board had enough information to make a determination on this. But if you guys would like, I'm happy to kind of go through some of the pros and cons quickly again, if you'd like, or I'll leave it up to you.
I'll make the motion.
Yeah.
I'll take one.
I will accept Mercer's recommendation on WebMD.
Can I amend the motion to amend it that we accept Mercer's recommendation on ASI Flex Benefit Health Solutions and Mercer's recommendation on WebMD?
Yeah.
I can second that.
The motion is on the floor. Are we ready to take a vote? Siobhan?
Yes.
Emily?
Yes.
Kimberly?
Yes.
Chiki?
I vote yes.
Thank you. Greg?
Yes.
Sean?
Yes.
The motion carries. Mercer's recommendations on the supplemental program renewals, all 3 are accepted. Which brings us to the big question. And perhaps Mercer, you would like to talk us through the options, and then we can come back and talk and consider the medical plan renewal.
Yeah, I can kick us off here. And yes, after much suspense, we do have 2 options that we'd like to talk through with you all, just to get the composite down to 3.4%. This is the first option. This is the Mercer recommendation. It has 3 components to it. On the left are the program changes. These are those that we went through today. And this is assuming that the board is in agreement with the Mercer recommendations, which has not been voted on. And so there's a possibility for that $4 million in cost reduction to go up or down depending on final votes. The second component is plan design change. And what we're proposing here is to increase the pharmacy copays on the Kaiser traditional HMO plan to align with the Kaiser deductible plan. And on the next slide, which we'll get to in a second, we'll show you how the pharmacy design compares across all PEBB plans. And then the third component is to use reserves. And so in this scenario, reserves are being used to buy down Providence Choice Plan and the MODA plan to achieve low-cost plan status. And so to do that requires about $14.5 million. And so taking into account all 3 of those components, it does sum up to a cost reduction of $21.4 million, which is the current figure that's needed to get to 3.4%. Let's just flip to the next slide and look at the pharmacy comparison before we pause for discussion. And so we have highlighted in that pink box what is being proposed to change. That is the current pharmacy copay plan design. And so with the proposed change, that would update to align with Kaiser deductible. So it'd be $5 copay for generic drugs and $25 for brand drugs. And so today the Kaiser traditional plan is the most costly plan. And it's only available to members in certain geographies based on Kaiser's service footprint. And so bringing it up to align with the Kaiser deductible plan would help manage costs in the long run for how Emery had described plan design changes and sort of the strategic justification of these types of changes versus using reserves. And the other comment I'll make is that even with this proposed increase to the copays, both of the Kaiser plans would still have the richest pharmacy design. As you can see, as you sort of look to the right and see MODA and Providence's current copays for pharmacy.
I just have a question, and I also just want to share. I know one of our board members who is not here today she had asked some questions around whether there could be more of a gradation for the Kaiser traditional plan rather than immediately going up from 1 to 5 and 15 to 25. So I just want to say that. And I also wanted to ask, so this 50% up to $100 for the brand, and there's an asterisk non-formulary brand drugs. Is it just different how Kaiser does it? Because it does mean on that brand drug line, it would increase the Kaiser traditional higher than MODA and Providence. Is that correct? Am I reading that correctly?
Yes, you're right. Yeah, okay. for the non-preferred brand drugs, that's right.
Okay.
Good point.
And do we have any numbers on how many people it impacts?
I don't know that we do. I can check real quick.
Because that was the comment too from our other board member was just that, and we talked about this a little bit with over-the-counter drugs, like any savings can add up when it's a lot, people are taking a lot of different drugs, so any increases can add up. So
non-preferred brand drug use would be very uncommon, not impossible, just the way our pharmacy systems and decisions were designed. That would be pretty unlikely. So
okay. So it's really then for most folks, it's going from 15 to 25. Is that right?
Yes. For those taking brand drugs, yeah.
Yeah, per brand. And preferred, of course, would be the 50%, or non-preferred would be 50%
Right. So that's helpful context.
And the 5 is still less than the other. So it would be going up to less than the other 3 plans.
When members are on brand drugs under Kaiser, typically they're steered towards their generic equivalents when possible, right? There is an exception process.
And they would be steered towards the brand formulary drug prior to brand non-formulary.
Yes. Right.
I just think it's, in practice, it's pretty unusual.
Which means it affects few people.
Right.
At the end of the day.
Yeah, that's helpful.
Okay. Any more questions or concerns about this that people would like to discuss? Hearing none.
Another option, which maybe will spur some discussion, is to just do away with that plan design change and let reserves make up the remainder. And so in that scenario, if you flip to the next slide, please, you'll see that middle component has gone away. And so now reserves are being used to achieve low-cost plan status for Providence, Choice, and MODA. And it's making up that remaining $2.9 million gap that's needed to hit that $21.4 million figure that we're trying to solve for.
And just a comment on that, I mean, it does mean we would be further subsidizing the most expensive plan that's out there now, right?
Yeah.
Okay.
Which is available only to people in the corridor metro
right.
areas. Yeah. Okay.
Yeah, and it pushes, it pushes like that additional amount into next year. So, either you have to do other kind of plan design changes or hope that trends and utilization's better or ratings better than Kaiser in order to meet that. So it pushes it down 1 year down the road, but it does, help the members at least in this initial year, like reduce, it doesn't have higher co-pays trade-off.
Thank you. Do I have a motion?
So I guess I have a question in terms of how process and how we're going to do this. Like, is it helpful that that we decided on an approach and then see if anyone wants to pull anything out of each of the plans to get there. Or, yeah.
We could also go back and look at those summary slides if the board is feeling adequately prepared to vote on those program changes. We could do that too, to understand if this $4 million savings is truly $4 million, if it's gone up or down.
Yeah. I mean, 'cause I would be happy to make a motion that we would go with option 1. I would just want to make sure that fellow board members are comfortable with then looking at each of the plans to see if anyone wanted to discuss anything further under this $4 million bucket of program changes. Right?
So, I feel comfortable with the Mercer recommendations in the first half of the meeting. So that's the first circle.
Right.
So that feels great. I feel comfortable with the second circle, which is what we just talked about, pharmacy change myself. I might want to discuss just for a minute, like just the idea of bringing up all of the plan, you know, like both Providence and Moda, and like up to you know, subsidizing them essentially, or if we wanted to do just one in order to ensure that there was choice in every area of the state, at least theoretically. I don't have a like strong position. I'm just like, it's like worth talking about for 5 minutes, you know. So it's kind of like 90% there for me, you know what I'm saying? So I don't know.
Let me ask this question. Is there any interest among board members in going back to the summary slides and picking through the plan, the design change recommendations one at a time, doula this? Is there any interest in doing that? Or would we like to stay here in this bundled zone and have conversations like the one that Sean is proposing?
I mean, similar to Sean, I'm comfortable with the program changes that Mercer recommended, so I don't need to go back through them.
Seems like maybe a little.
I'm where you are. Yep.
Okay, Chicky?
I'm good with it as well.
Okay, all right, then let's stay here in this bundled zone, and I'll open the floor back up to Sean to talk about this reserves question.
So, yeah, so I think just to talk through, you know, so the I-5 corridor and then rural Oregon, just to oversimplify a bit. And the question at hand is, do people have a choice for a plan other than the statewide, which they, if they were to choose, you know, that's the higher cost share. So that would be like a limited choice, which would bring us to the folks that are kind of like out of state. That whole discussion is just like, they have no choice, you have to do. And so I think we understandably want to avoid that as much as possible, which is where people don't have a decision to make. They're just like, I have to do the most expensive plan because that's all there's available. So that's, I don't feel like that's a question. I think we're probably all on the same page there, that we want some choice. And so my understanding is for the third circle here, is that we're deciding to buy down Providence Choice and Moda so that they are available kind of all round as a low cost plan. Yeah. Moda, which, just to be clear, this for the sake of discussion, like I could get behind. I just kind of want to talk it through for a minute. Moda is close already, real close. I don't know what the dollar difference is between, like, if the bulk of this 14.5 million is buying up.
It is.
Province.
It is.
Okay. So that's just sort of the discussion. Like it's actually kind of not that big of a bump to move Moda to buy them up. It's bigger, like the bulk of what we're doing here is buying up subsidizing choice, right? So that's just the discussion. It's like, yeah, that's all. It's just a topic.
So I want to
Please.
weigh into the discussion. So I actually do feel strongly around accessing our reserves to benefit our members. I see this as part of their total compensation. And I also see when the legislature takes money from the reserves that we've set aside, that's taken away from people's total compensation. And so it is also true, it means we have less to work with in the future. Additionally, to me, it feels at this point like we just have a big target of saying, come raid this pot of money if we don't utilize it in a way that benefits our members. And going from a 1% to a 5% is a steep increase for folks. And I don't think it's beneficial for people to go into open enrollment and be like, may as well be on the statewide plan if I'm gonna have to pay 5% at Providence or 5% at Providence Choice. So Providence statewide versus Providence Choice. So that's where I would go with this. I would support this.
To take Siobhan's observation one click further, it winds up looking like PEB members subsidizing the general fund when our reserves get raided. And we don't get notice in time to reinvest, and we didn't know when we came that that was what we were signing up for. But that brings our window of utilizing that fund much more narrow if we want to have command, and that's our members' money. So using it to benefit members in the most equitable way possible, as both of you have identified, is part of why I have more comfort buying it down, even though it leaves us with less margin. The fact is that lower margin is what makes it less of an attractive target for the legislature to redirect at their discretion.
Yeah, I mean, that's certainly a reality that we face, right or wrong.
This year's the first year for the choice plan that we don't have to worry or have problems with the and I've lost it. Referrals, thank you. With referrals. It has been a really hard road, and nothing to do with choice, nothing to do with you as the member, but we've had a lot of issues with doctors getting those referrals to you in time. This year, of course, I go see my primary, and at that point, if I want a referral, I can just, see who I want to see as long as they're in my plan. And so we're not sure really, this being that first year doing that, I'd like to make sure that the plan kind of stays where it is, because I'm not sure if it's going to be better for us or if we're going to have more buy-in, which may get us less money in the long run coming out of that. And to bump that up when we've done a pretty big move like that might also hinder some good stats for us as well, or some dollars down the road. And being from rural, a lot of us, just in general right now, where funds are, that the dollars that I have are the dollars I use, and being able to stay on a lower plan and the money's there from our members to use, I think is a good thing to do.
Any more discussion at this time?
So given that, I will make a motion that we go with Mercer's recommendations for program changes, plan design changes, and reserves as presented, option 1 on page 37. This one, right on the slide.
This is Kimberly Hendricks. I'll be happy to second that motion.
Thank you.
Sorry.
All right, then let's go to a vote, please. Siobhan, how do you vote?
Yes.
Oh, you placed the motion, yeah. Okay, Chicky?
A resounding yes, please.
Emily?
Yes.
Kimberly seconded. Greg?
Yes.
Sean?
Yes.
The motion carries Option 1 is approved as submitted by Mercer. Thank you for all the work to set up a decision that we could understand and make.
Thank you, board members. We have one more section here on weight management solutions. There are some options in here that would require a board vote. However, they do not impact the composite. And so we're thinking it makes sense to go through this section as opposed to going through and are we good with the program changes? It sounded like there was agreement for the first part of the deck.
Yeah, the program changes.
Okay, great. All right, Sarah Drake, if you're still with us, I can hand it over to you to set the stage with, what discussions have been had thus far with adding coverage for GLP-1s for weight loss.
Thanks, Andrew. And this is definitely just a continuation of the conversation that we've had during the last meeting and then also the CL group. As we've discussed, I think at length, this is a category that is really unique. It's a really unique situation because there are a lot of members who would likely benefit from addition of a weight management drug benefit that included the GLP-1s. But at the same time, the cost of the drugs is such that it's difficult to add that coverage within that 3.4%. And as we discussed last time, our recommendation is at this time is to continue to defer with additional work done between now and 2025 over the summer to continue to look for opportunities in the market, look for chances for innovative purchasing, not other weight management solutions that Christy will be talking about later. You might have heard as well that Wegovy, which is one of the common drugs for weight management, a GLP-1, did receive FDA approval for reduction of cardiovascular risk for people who are both obese and have a history of cardiovascular disease. It's likely that that coverage may become available through the regular formulary process with the plans, but that would be for a small subset of people with obesity, likely less than 10%. Other things to think about here, I want to point out that it is really an important category for members. Heard a lot of public comment, including some that came in for this meeting from the American Diabetes Association, and the importance of reduction in weight in terms of preventing diabetes and preventing costs in the long run. The information provided in the public comment did provide some numbers on potential savings associated with weight loss. At the same time, based on my read of the document, it did not include the cost of covering these drugs, which is over $1,000 a month. So with that, I'm happy to take any questions. We've definitely discussed this at length. It's not the recommendation that we want to make, but it's the recommendation is realistic given the constraints of the PEBB.
Just a comment, the one piece that I want to underscore that you were saying is that it may be the case that over this next year even, not even in 2025, that it could be that formularies change to cover a subset of folks who have heart conditions and are obese. Is that, understanding that correctly? So that could happen, and that would just happen as part of the plan saying, yep, we've got to do this as part of taking care of folks.
It's a possibility, yes, because previously the drugs were only approved for weight management, but now the one drug has an approval for cardiovascular risk reduction for a certain subset of people who have obesity. The plans are still reviewing. We don't know how it's going to turn out, but I think it's definitely a possibility that there could be a path to coverage for people who meet that more narrow criteria. At the same time, I think the manufacturers of these drugs are continuing to do research, and over the next couple of years, we might see additional indications for diseases like fatty liver disease or other conditions that might affect people with obesity. But it's too soon to say for sure what's going to ultimately get approved.
Okay, Thank you.
But Sarah, it's correct that that this was not the only drug you can give somebody with obesity and heart disease. I mean, you know, it's not like we're coming into a new.
It's not the only drug that can prevent cardiovascular risk, right? So drugs like statins, drugs for high blood pressure, there's a whole suite of drugs that can be used to prevent cardiovascular risk. Most of those other drugs in the market don't actually treat obesity at the same time. So I think that's what this is meaning.
Yeah, but it's not like we're saying no to something. There's nothing else we can do.
Can you remind me, are current people with diagnosed with diabetes, are they currently approved for this drug?
These drugs are not currently covered. So there's 3 GLP-1 drugs that are approved for weight management or weight loss: Wegovy, Zepbound, and Saxenda. None of those, all of those products are excluded from the plans currently. It's not part of the plan.
But Ozempic,
We cover Ozempic, which is also a GLP-1.
One of these new ones.
Semaglutide, but we don't cover the semaglutide that only has the FDA label.
Yeah.
We do cover.
Ozempic is covered for people with type 2 diabetes, and the same for other similar drugs like Mounjaro.
It's a slightly different
Same.
dosage. Right.
Yeah, the semaglutide for Wegovy can have a higher dose.
Same drug, slightly different doses, branded differently.
Well, the brands are very important. So is it true, like, are they, if you're diagnosed as pre-diabetic, are you, are these drugs approved for people that are diagnosed?
They're not. They're not. Currently, there's no FDA. There's no FDA approved drug for pre-diabetes. There's a number of evidence-based programs that can prevent diabetes. I think including some of the ones that are incorporated into the plan. I think there's some great information on the CDC website, but about 30% of adult Americans are believed to have prediabetes. That's a very prevalent condition. GLP-1s and no other drugs are FDA approved. I believe the American Diabetes Association does recommend metformin, which is a low-cost generic drug for some individuals who have prediabetes and high-risk factors.
Okay.
If they're lowering blood sugars and lowering weight, they will help with prediabetes. But the FDA approval hasn't been sought. It was studies haven't been.
Yeah, that's not a current existing reality. Okay, all right, thank you.
So just to summarize, there is a GLP-1 medication available through our plans currently covered if you meet eligibility criteria that include diabetes and other criteria. There is not access to these medications solely for the indication of obesity. And the current analysis is that our cost to add coverage, given that over 30% of Oregon adults could potentially qualify for treatment based on the FDA approval for obesity, that we are not able to meet that cost at this time. Is that the recommendation?
Yes.
That's correct. And you can see on this slide the estimated cost to add the coverage that was provided by each of the 3 carriers. And that does not assume that all 30% of people would access the drug. It assumes some reasonable uptake rate. Kaiser estimated over $6, $6.84 per member per month. Moda estimated 1.7%, and Providence 2%.
Thank you. I want to acknowledge that the research for these drugs is in a phase where, if I'm not mistaken, the body of evidence is growing rapidly. So even if we defer for a year, there will likely be more to understand by the time we come around and consider again.
Absolutely. These drugs are being studied for so many conditions beyond diabetes and weight management. I mentioned the fatty liver disease. I think they're being studied for diseases like Alzheimer's. There's a lot we still need to learn on these drugs, but I don't think demand is going to slow down anytime soon. There's a lot of people who are really hoping that have a chance to try one of these drugs because they've tried a lot of other treatments for obesity. The challenge at this time is fitting the coverage in to the limited premium increase.
Thank you.
I mean, I think it makes sense. I mean, I don't think we have any choice but to defer, but I would just add that we ought not wait until the literature solves it for us, that in the intervening year, we should be planful about what this may or may not look like for us as far as what other requirements or plans or whatever. I'm not saying that we would lead our own study, but I'm just saying it would be good to have some plans in motion so that we don't get to the next year and be like, man, it's really hard, you know, so.
Thank you.
I would just say also that as a drug enters into the population outside of the construct of a study, then you start to accumulate knowledge about downsides and complications that may not arise in the course of a controlled population. And so it is new. I mean, even though it's been in the diabetes world management, and for the general population, it is a new drug. And so I think from a safety and management perspective, besides the cost, going after this in a way where the utilization is managed, it's not just a script and you're off on your own, may be worthwhile because some other things are emerging, osteoporosis, muscle mass loss, other, you know, things, people that can't tolerate it, and you just don't want to sort of let it go in the population. So those are other things that are also emerging in this time frame.
Thank you. Chiki, if I may. Chiki, you have your hand up?
I do. I have a question. So I'm looking at the potential 2025 efforts. Are we waiting that long to start the potential 2025 efforts? Because it's only April of 2024. So that's my first question. And then my second question is, for those strategies, especially bullets 2 and 3, can we expect that there will be no cost or absorbed with existing expenses, or it will be absorbed by carriers for all these mitigation strategies?
Yeah, that's a great question. We're definitely not waiting until January 2025. These are conversations that we want to continue to have with the carriers. We're continuing the fourth bullet. We're doing that now, right? And then ultimately what we're hoping to see is that as more drugs into the market, as production stabilizes and we don't have shortages anymore, maybe there'll be opportunities for purchasing the drugs at a lower price, because that's really the barrier right now is the price. So we're trying to understand what those opportunities are. Christy's going to talk a little bit about some of the non-drug weight management options. So you'll hear about those in a bit. And then that third one around the optimal prescribing network, that's work to understand if the benefit were to be added, what could be done to make sure that all of the members might have a similar quality experience. What we don't want is just prescribing and only prescribing without some oversight and making sure that members are likely to succeed in their request journey.
And sorry, that's what I wanted to add is at MODA, you know, we have been looking at this market change before it even launched, and we continue to talk with industry partners. And as Sarah said, with more market launches in this space creates more competition. And so talking with the manufacturers of these products and saying, what more can we do? What more can we do to position your product maybe over other products and have that financial conversation? So we're not giving up on that. And so that work is being done behind the scenes. So, you know, we're not waiting until 2025, and we're hoping to make headway in some of those considerations that Sarah had mentioned.
Thank you. So let's go ahead and work through these last couple slides to talk.
I think Chiki's hand maybe came up again.
Oh.
No, it's fine. I was just going to request if it's possible to maybe get like a half-year mark kind of update so that we can track things a little bit more closely and make iterative approaches or changes as needed. So it was just a request if it's possible to get halfway through 2025 versus waiting full year to hear about how those potential efforts worked. Thank you.
Absolutely, Chiki. I got a couple nods over here from Mercer staff and from Ali. Let's go ahead and talk through these last couple of slides around weight management. We do need to look at a vote on on those recommendations. Let's do that first.
Great. Thank you, Dr. Mautner. Hi, everybody. I was just going to, as they said, talk through a few slides here. So just wanted to level set with kind of what the current weight management and diabetes support program landscape looks like. One thing I just want to note here, too, is that this is not the full spectrum of needs of members. Obviously, there are higher clinical needs and higher acuity needs, from maybe somebody that is living with an eating disorder or some of those other components. Also excluded from this slide is the care that a person would receive maybe from their primary care provider or a specialist. So really what I'm focusing on here with this landscape is really the programs that are in place to support members. Also, there's a few things as I go through this, I'll point out that we had some additions to this that are not on the slide. So first of all, for carrier programs, there is one-on-one health coaching in place through Kaiser, Providence, and MODA. On here, we say, Kaiser and Providence have it specifically with a registered dietitian. Also, Kaiser has some group classes that also support weight management and overall health. And then Providence has their HEAL program, which is an in-house diabetes prevention program. Several of the carriers have OMADA in place. The diabetes prevention program currently is in place through Kaiser. And then Providence has the OMADA prevention program in place. These are very similar programs. The diabetes prevention program just has a pre-D eligibility requirement, which is either, a reported elevated A1C or glucose measurement, or completion of the CDC's pre-diabetes questionnaire and having a specific score on that. Also within the current landscape is VERDA. VERDA is actually offered by MODA and Providence. Right now, it is offered as a diabetes management program for those that are diagnosed with type 2 diabetes. VERDA is a clinically effective program that is really focused on nutritional therapy using a carbohydrate restrictive approach. And then, as we all know, Weight Watchers is also in place with all three carriers. So all members, through MODA, Kaiser, and Providence have access to Weight Watchers. And, it has the virtual program in place with the Weight Watchers framework. Additionally, and this is a new one on from 1/1 of 24, Sprout at Work is being offered through MODA. This is a wellness platform. It does include the health risk assessment that is part of the health engagement model for those members that are have elected to have MODA. Additionally, it has really good device integration for tracking of activity behaviors and other types of behaviors that a device would track, so that it's all in one place for members to see. And then also has a good library of access to videos and educational content. Also in place right now is Active and Fit Direct. This is a discounted gym membership program. I also want to point out that Providence has a program like this. They had Active and Fit prior, but they did switch this year to OnePass. So a very similar program is also in place through Providence. MODA has Livongo in place, which is a diabetes management program. One of the biggest benefits of the Livongo program is that it does provide the smart glucose monitor, testing supplies, and access to health coaching. And then lastly, we have Kaiser has a Choose Healthy program, which is providing discounts to members for a variety of services. And then I also wanted to share Providence has a similar program in place, and that one's called Life Balance. And that also has some discounts on services for members to take advantage of. And then if we move to the next slide, so as we've talked about today, as part of the CIAO summer work group and looking at GLP-1s, we also wanted to ask the carriers to provide some alternatives of different ways of supporting members with weight management, knowing that one size does not fit all and that there's different program components and approaches that are going to work for some different than others. And so out of that request, we have two programs we wanted to bring forward. Mighty Health is a proposal from MODA and Providence. Mighty Health is a very holistic approach. It actually has a focus on many pillars of a healthy lifestyle. It has an approach of chronic pain, so helping people navigate and doing lifestyle behaviors to help with chronic pain, healthy eating, sleep, emotional components, and so really holistic in its focus. The other really positive benefit about Mighty Health is they have very functional and accessible movement videos, really to meet people where they're at. So there's chair yoga, there's just a plethora of different options available. And it is integrated with Apple Health and Google Fit so that that data can be used. So part of what we've talked about previous as far as how we want to go about pricing of programs to really make sure that there's value and quality from the program is really an engaged user's approach to this pricing. And so you can see here that Mighty has that approach. And the Mighty prices here also include a connected scale. Mighty Health does include a health coach as well. So that way then with that connected scale, when the member meets with a health coach, they have those, different types of data to talk about in addition to behavior change principles. So in the pricing, months 1 to 5, is that $40 for those per engaged users per month. Then knowing from month 6 to 12 that typically an engaged user, if they're still engaged in month 6, they are moving more towards that really activation stage and have had some success. And so that per engaged member pricing then drops to the $25. And then really moving into months 12 to 36, more in that maintenance phase, where having support and program and knowing you have a health coach you can always reach out to is super beneficial. But that really, that higher amount of support is not necessarily needed. And you can see that that per engaged member per month pricing goes down to $8. And Mighty also is willing to put 50% of fees at risk for that minimum of 5% weight loss. The other program I wanted to talk about today was just Omada through Kaiser. And so as we said previously, Omada is currently in place for their diabetes prevention program. Kaiser proposed opening it up to their weight management program, which is a very, very similar program to the diabetes prevention. It just removes that eligibility requirement of having that pre-diabetic either A1C or glucose reading or the completion of the CDC pre-diabetic questionnaire. The cost for this program is $155 per participant per year, which does include the cost of the connected scale. And it sounds like there is a willingness to negotiate some fees at risk with Omada. So I'll pause a minute and just make sure, are there any questions on these two programs?
Only confirming these are also outside the 3.4%, right?
Yeah.
All right, and then I have one last program to talk about, which is Weight Watchers. And so with Weight Watchers, as we know, it's been in place for quite a while within our PEBB membership. And we really, again, moving towards this kind of engaged pricing model, have been working really closely with Weight Watchers and trying to revise what that pricing model would look like. And so you can see here on the left is kind of current state and where the pricing has been. And then our recommendation is really to move to the engagement-based option, similar to what I just went over with Mighty Health, where there is that engaged active member who's enrolled and doing some type of engagement activity twice a month. There's a variety of things a member could be doing that would be considered engagement, whether it's recording their weight or maybe doing a food journaling or participating in a session. So with that months 1 through 5, again, you can see the two different prices there. One is without a scale. The second price is with that integrated scale. Again, then once we move into those months 6 through 12, pricing drops a little bit again because most support and less support is typically needed at that time, but it's always great to have the resources there and knowing that somebody can continue recording and using the website to do what they'd like to do. And then lastly, again, moving into that kind of maintenance but ongoing support phase is those months 12 through 6, where again, you can see that pricing goes down to 25 without the scale or 27 with the scale. And so I guess, Dawn, I didn't know at this point if the board wanted to make a vote, if that was necessary today, but you can see here our Mercer recommendations are to go forward with Mighty Health through Providence and MODA, and with the Kaiser OMADA program for weight management, and then also renewing Weight Watchers using the new engagement-based option.
Thank you very much. Do I have a motion?
So I'm open to making a motion that we adopt the recommendations as seen with Weight Watchers moving to that renew with engagement-based option, as well as Mighty and OMADA. And also as part of that, taking Mercer's recommendation on deferring the weight management drugs is kind of an overall picture. Just want to add in Chicky's point around checking in as more and more developments happen. Additionally, I think we named in the last meeting, we're going to continue to engage in a work group with board members as well, correct?
Yeah.
Yeah. So that's my motion.
I'll second that.
Motion seconded. So we have a motion to accept Mercer's recommendations on all 3 of those last items.
Can I actually ask a clarifying question about the engagement, the alternative engagement-based option with Weight Watchers? And so just because I'm actually on the program, and so I'm just wondering like how that would change my experience with the program, for example, or others. So can you review that, Christy, or just like, so there's this engaged active member, which is defined as doing two actions per month.
Right.
And then the second, could you go over the second and third categories again?
Sure. So I think from the user's perspective, there's really not going to necessarily be a change or a disruption to how you're experiencing the program right now. It's more so how Weight Watchers goes about billing and offering the program. And so really it's just saying that we want to make sure that there's some engagement metrics in place that a user is participating in order for PEBB to be billed. So if somebody, and they did give, and sorry, I've closed some of my my slides here because my Wi-Fi, sometimes I don't show up very well. So they did give some scenarios. So like if somebody were to say engage for a few months and then let's say drop off and not engage for a few months, how does that pick back up? And again, for the member, you don't have to start over. You're not starting back at month 1 and having to enroll again. But it's just, again, is that PEBB was not being charged for a month that a member is not engaging in the program.
Okay.
Does that make sense or answer your question?
Yeah, I think so. I just, there's so many improvements to the Weight Watchers app. So for example, there are now like identity groups. So you can connect with the LGBTQIA, plus group or the Black women group or caregivers group or Latinos group, or just, so like if somebody were to do these virtual groups, instead of like coming in to get weighed somewhere, like does that count as an action?
It does count as an action, yes. And I can do a follow-up just to really define what those actions are. It was just really meant to be the engagement is a wide variety of items that somebody can engage in order, to kind of qualify as engaged. And it's more, again, so that we know that people aren't just enrolling and then not using it. And then PEB is on the back end being charged for that. So making sure that there's some sort of engagement in order for that to create a charge to PEB.
Okay, so no change to the member experience, only whether the carrier is getting charged.
Got it.
Correct?
Okay.
Correct.
Okay, great.
Thank you.
Yeah, you bet.
Question on the moving to this, is it, and I don't know how this would work, but is it, so let's say I've been doing Weight Watchers for a year and a half now. Am I going to start over as a brand new member in this and be charged $40 a month? Or are we getting some kind of a list that shows our members and the months that they're in that will then say, we're going to start charging your members at X? If you understand what I'm asking.
I do. Thanks, Greg. That's a great question. I don't know if we've gotten into some of that nitty-gritty details with the Weight Watchers team, but I'm happy to take that as a takeaway and follow back up.
I mean, yeah, if we, we go with this, which, looks like we're going there. I just want to make sure that we don't end up paying, everybody's now a new customer. I don't think they're going to do that, but I just want to make sure that on the back end, when we tell people we moved to this is why we did it, this is where we are, and we can show that this is what the cost was, just for us.
Yeah, that makes sense. I do. So currently, the only thing that we want to make sure of is I don't believe a scale is incorporated in the current program.
But I understand that.
Yeah, so we would make that available to current members so that they have that same kind of program experience as a new member would have.
Right. So if I'm in month 7 and I decide I now want to scale, then I would be charged. We would be charged 37, not 48 as a new customer. If I'm in month 1 to 5 and I want to scale, we would do the 48 till month 6. Then it would be ducked down to 37. Then if I continue at 12 months, we're down to 27. That I understand, as long as that's the way it works.
Okay. Yes, I will dive into that nitty-gritty details and get back to you on that.
Thank you very much. It appears to me that we have another question. Yes.
Discussion on the motion, yeah. So I'm prepared to vote on it with the highlighting the in Mercer's proposal here, slide 43, that I'm presuming that we are following through and we will be getting some fees at risk with these programs. That's my vote's contingent on that.
Perhaps we want to. Do you want to propose that? So that is.
It's in there.
Yeah, I'm just highlighting it.
Okay.
As like,
Lifting it up.
yeah.
Amplifying it. Got it.
Like, yeah. I mean, they're willing to put up fees, and I'm saying I'm willing to vote if that's the case.
With the contingency that fees at risk need to be negotiated and exist.
Correct.
We have a motion to approve recommendations for all 3 components of the weight management benefit, including deferring obesity-based GLP-1s, adding these 2 vendors, both of which have put fees at risk, and renewing with the engagement-based option for Weight Watchers.
Very good.
Yes.
Let's take a vote. Siobhan.
Yes.
Yes. Cheeky.
Yes.
Emily.
Yes.
Kimberly.
Yes.
Greg.
Yes.
Sean.
Yes.
The motion carries. Thank you for your recommendations and bringing us a doable decision. And thank you all for your patience. I know we've gone over. Anything else for the good of the order?
Public
public comment would be definitely for the good of the order. Is there any public comment, please?
No, no public comment.
One that was sent.
Yeah, the week all gone.
Thank you, Rose. There is the one public comment that we all received.
I know, just
Acknowledge that it happened. So acknowledgement of the written public comment that was received by all the board members. Anything else for the good of the order? Hearing none. Thank you for your attendance and your patience. And this meeting is adjourned.